The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi everyone, good day. This is Dr. Ruby Punongbayan, a pediatrician. My training is ambulatory and emergency pediatrics. So I've been working as a pediatric emergency medicine consultant for the past 20 plus years, and I've been with Top Notch since its inception, and I'm so proud to be a part of their family. So what I will do is to highlight all the important things about common pediatric conditions that you may encounter not only during the exam but as well as in your in actual clinics or in actual patient encounters. So a part of this presentation, of course, is I will share with you the the pediatric cases that I have handled through the years, and hopefully that will facilitate your learning and remembering all the important points about each common pediatric condition. So to start with, let's talk about pediatric neurology. So whenever you encounter a condition presenting with seizures, okay, or convulsions, they are actually synonymous. Of course, this will be presented as changes in the motor activity in the brain, which can be manifested as either having upward rolling of the eyeballs and or stiffening of the lower end as well as upper extremities. So any change in the motor activity definitely is seizure and warrants immediate intervention. So these are the cases that are immediately brought to the ER. You see them actively seizing, or if not, sometimes the seizure has ceased, has stopped during the transport of the patient, and yet you will see them post-ictal, so just right after the seizure. So which means they are not really that alert, but rather lethargic. But when during history taking, when you ask that how many times the seizure has taken place from the home up to the time that they reach the hospital, sometimes if there are already 2 or more unprovoked seizures occurring in a time frame of more than 24 hours, then that could already be epilepsy. And when we're talking about epilepsy, it is important for us to identify whether you're talking about a syndrome wherein there is one or more seizure type with a specific age of onset and prognosis. Okay, so as we go along again, I'll share with you the 2017 International League Against Epilepsy classification of seizure types. Again, not only this is useful for the board exam, but again in actual patient encounters wherein you are first to identify what is the seizure like. If the patient or the person in at question, no, will present with seizures in the ER or say in the primary care setting in the OPD, you identify are the seizure activities more focal, generalized, or basically the third one is of unknown onset, under which you will have subclassifications. Under focal, you have motor types or non-motor types. So here in motor types, under focal, the main umbrella or classification is they are either aware or there is impaired consciousness or awareness. But they will have some automatic behaviors, automatisms, say like pedaling. It's as if they are doing a bicycle or riding a bicycle and have pedaling movements. In neonates, you may have lip smacking. Okay, so these are some of the automatic or automatism behavior that you will see. And then for tonic, it says that it is described usually as having stiffening of the extremities. And you may have clonic tonic-clonic type of seizure wherein there is jerky movements. But when the parents say it's tonic-clonic, meaning the extremities involved are stiff as well as they have jerky movement, so that's tonic-clonic. Myoclonic, of course, is when there is regular sustained jerking. So this involves brief muscle contractions which result in jerky movements of certain muscle groups. So that is myoclonic seizure. Atonic is literally drop attack. There is dramatic loss of posture, loss of body tone. So when you say atonic, sudden loss or diminution of the muscle tone, which lasts in just a few seconds. It may involve the head, the trunk, the jaw, or I'm talking about the big muscle groups. So ito yung biglang literally bumabaksak, no? Atonic type of seizure. And then you have the epileptic type wherein 2 or more unprovoked seizures have been happening in the course of the 24 hours. And then you have hyperkinetic. For the non-motor, you may have emotional, sensory, again, autonomic type of seizures, cognitive, and behavior arrest. In behavior arrest, it may be manifested as freezing or activity or something like the parent would notice that the patient cease to do, let's say, he's writing or drawing or playing around, but then at some point, when the seizure sets in, there would be cessation of these activities. Okay? So for generalized, basically, this would involve all the upper and lower extremities. Okay, and you will see that for generalized seizures, it will either be motor or non-motor as well. And again, we have unknown onset, but may also exhibit with tonic-clonic type, meaning combination of stiffening of extremities as well as having jerky movements, okay, and epileptic spasms, wherein most notable would just be trunk flexion. Okay, so this has been the classification that we've been using since 2017 as proposed by the International League Against Epilepsy. For neonates, just the past 2 years ago, February of 2021, the particular classification for neonates, classification of seizures, highlighted that whenever a newborn 0 to 28-day-old babies present with seizure, they are usually focal at onset, and then they may have clinical manifestations. Some may not be accompanied with clinical manifestations. And then it could also be either motor, non-motor, and sequential type of seizure. And again, highlighted here is doing EEG, definitely in the diagnosis of seizures in this particular age group. So when the test question appears to you mentioning the age which falls under the 0 to 28-day age group, take note that these are all focal and could be either motor and non-motor, and then we should do EEG at least 24 hours after the onset of seizures. So again, when you are dealing with long questions, like the STEM question is a clinical one, and you need to identify, let's say, whether this is focal or generalized. And then okay, you need to identify whether it's focal or generalized, motor or non-motor, what are the associated symptoms and signs, and then what are the medications given, or has there been any maintenance medication so far? Okay. And important is for those who have already been diagnosed with seizure, has there been irregularity in the giving of maintenance medications? Why? Is it because financial constraints, like there's no access to buying the medications, or maybe There has been weight gain so that there is now underdosage of the maintenance medications, hence the onset of a new seizure. Then we call it breakthrough seizure. Okay? So again, it entails workup wherein, especially for seizure disorders who have already been there, no, as a diagnosis, we look into the possibility of breakthrough seizure. Workup then would be at least levels. We get levels of, let's say, um, what is the maintenance drug for this particular patient. Let's say that the patient is on phenobarbital for 1 year, and then there has been a breakthrough seizure. Part of the workup for that is, of course, having a level or an assay of phenobarbital or maybe valproic acid in order to determine how low, or whether we need to readjust the dose of these medications. Okay, so these are the important parts that you look at the overall condition, the overall the data that is given in the STEM question, so that you will be able to at least answer what is being asked, such as basically they would ask there, the examiner would, what kind of seizure is this? Okay, what is the medication for such activity, for a focal or a generalized seizure? Okay, so this is the approach to that. Now, let me go to the seizures or the seizure disorders one by one, and I will be highlighting the most common one. You have first the West syndrome. West syndrome is previously called infantile spasms. So from the term itself, infantile spasm, the age group definitely is affected is the 2 to 12-month-old age group. Okay, infant. And then the triad now is, you see epileptic spasms. So there's one, infantile epileptic spasms. Then the STEM question might include or might state that there is developmental regression. So take note if there is mention of developmental delay, such as motor. Let's say the patient is already 9 months old, and then the patient isn't able to sit without support. Previously, at 6 months old, the patient is already able to do that. But if there's regression or even delay in the acquisition of such milestone, in this example, I'm talking about a motor milestone, being able to sit without support. So if there's regression, if the patient's epileptic spasms happen during infancy, and if you do the EEG, you see hips arrhythmia, this is the triad for West syndrome. When you say hips arrhythmia, you can see here on the right side of the slide that there is chaotic slow waves that are superimposed with multifocal spikes. You see this, there are spikes, multifocal or sharp waves. Again, the pattern is called hips arrhythmia, part of the triad of West syndrome, particularly affecting infants. We give ACTH, that's your adrenocorticotropic hormone, and vigabatrin. Your ACTH still has an unknown or established real mechanism of action. However, experts are using this for West syndrome because they are thinking of the medication's ability to reduce neuronal excitability by lowering the production and release of CRH. Next, we talk about seizures happening during childhood. And one of the common ones is what we call benign childhood epilepsy with centrotemporal spike. I know it's a long term, but Nelson, Textbook of Pediatrics, has this long phrase or term for that particular epilepsy happening during childhood. Previously, this is known as Rolandic epilepsy or benign Rolandic epilepsy kasi galing dun sa Rolandic part, no, of the brain. So this particular epilepsy or seizure disorder obviously has its roots coming from the centrotemporal parts of the brain. There are spikes there that would be seen from the EEG. Since this is childhood, again, the age range is 3 to 10 years old. The good thing here is it is outgrown during adolescence. How do they present? They have vocal seizures with tonic or clonic contractions of one side of the face. Then you see them drooling. Sometimes they are unable to speak, but still awake, preserve consciousness, but you see the contractions of the face. Okay? So sometimes they are awakened at night or early morning or in the middle of the sleep. They are awakened by this. There are contractions. So if they don't have anybody beside them in the room, so sometimes it's very difficult to catch this type of seizure. Okay, but note that again, the timing, most of the occurrences would happen at night or in the middle of the sleep or just waking up upon waking up in the morning. If you do, this is EEG. Okay, sorry for the typographical error here. This is EEG, wherein you will see again the broad base spikes, basically from the centrotemporal area. MRI is normal, and they respond well to anti-epileptic drugs, and the first line drug for this is carbamazepine. So again, this is benign childhood epilepsy with centrotemporal spike. Now, there's another type of epilepsy during childhood, but this time the spikes are coming from the occipital portion of the brain. So I'll just mention two. First is Panayotopoulos type in Nelson. This is described as early onset childhood occipital epilepsy. So during early childhood, like 2 to 5 years old, 2 to 6 years old, and they present with partial seizures with ictal vomiting, retching, and spitting. So meron siyang mga automatism, okay, automatic or automatism presentation, okay? So for this type, Panayotopoulos type, they would respond to oxcarbazepine followed by carbamazepine. The other type of childhood epilepsy coming from the occipital portion is Lennox-Gastaut type. But this is much more common during later childhood. So the latter part of the childhood, meaning 6 to 9, 6 to 10 years old. There are also partial seizures. There are visual auras. So they see like flashing of lights prior to the onset of the seizure and a migraine type of headache. I'd like to emphasize in this part that there's a triad. The triad is composed of there's developmental delay in these children, multiple seizure types. So they can present with tonic seizure, stiffening of extremities, clonic, ibig sabihin, jerky movements. They may have myoclonic, no, contracted muscles or big group muscles, and then you have delayed intellectual development as well. Okay, so the behavioral problems with this Lennox-Gastaut type, the children could have aggression, agitation, hyperactivity, and autism. Hindi naman lahat yun sabay-sabay, no? But this is the spectrum of possible manifestation of behavioral problems with those with Lennox-Gastaut type. So the treatment is valproic acid followed by lamotrigine and topiramide. Okay? And then we move on to the next age group. Okay, from latter childhood, we now go into adolescence. There's a particular epilepsy or seizure disorder here known as juvenile myoclonic epilepsy, previously known as Jan's syndrome. Okay, the proponent, the one who first described it was Dr. Jans, obviously. So in this type of myoclonic epilepsy, there are jerky, irregular movements of both arms, typically occurring within 1 to 2 hours after waking up or taking a nap. So just as they are waking up, no, from an afternoon nap, there would be dramatic jerky movements of both arms. This could be idiopathic and hereditary, occurring between 12 to 18 years old, usually requires lifelong treatment. Okay, the most effective for anti-epileptic drug for this is valproic acid. However, if the patient is already of a childbearing age, we usually would give lamotrigine. Okay, lamotrigine would be the recommended anti-epileptic drug for women childbearing age who have this John syndrome. Okay, and then the last anti-epileptic drug, I mean, in the hierarchy, then we have valproic acid, lamotrigine for those who are of childbearing age. Then we can also use levetiracetam. Okay. What is the course of the illness? What are we looking at in terms of prognosis? Those with John syndrome, they tend to improve after the 4th decade of life. So you have to contend with long treatment with anti-epileptic drugs. Now, some generalities in the management of seizures and epilepsy. In general, if the risk of recurrence is low, like the neurodevelopmental status is normal, there are no delays or deficits, okay? Long-term therapy is not indicated. If you have normal EEG and MRI as initial results out of your diagnostic tests, long-term therapy is not indicated. Remember, your anti-epileptic drugs will reduce excitability by interfering with sodium, potassium, or calcium ion channels. They basically reduce excitatory neurotransmitter release or function, and they enhance GABAergic inhibition. So as you can see, if you look at the pharmacologic side of anti-epileptic drugs, most of them have multiple mechanisms of action, but treatment is individualized. Such as this, no? This table was lifted from Nelson Textbook of Pediatrics again. So in general, if you are dealing with focal type of seizures and epilepsies, the first line drug would be oxcarbazepine or carbamazepine. You may know this as Tegretol, okay, the usual brand. But of course, there are other brands, no? Sometimes lang kasi, you might have encountered consultants as you were doing your clerkship and internship mentioning the brand name, no? So I'm just trying to review you with all of the brand names that are popularly used. For absence seizure, you know that absence is temporary cessation of activity for several seconds. They don't have aura. This just happens like, diba, nagbi-blink-blink lang ng eye o naka-stare or staring spells. Yung parang ginagawa nyo ngayon, nakatingin lang doon. Okay? Or yung mga, of course, I'm joking, but the children who appear to listen and to be attentive to the teacher pre-COVID days, no, in the face-to-face school setting, sometimes they are just staring there like that, but there's cessation of activity actually. So that's absence seizure. And the first line drug, of course, is ethosuximide. Alternatives would be lamotrigine and even valproic acid. For John syndrome, as I said, valproic acid talaga, no, for males and actually females. But again, if they are of childbearing age already, the recommendation is to give lamotrigine. For Lennox-Gastaut syndrome, we already mentioned this earlier, clobazam, valproic acid also. For infantile spasms, remember, West syndrome, okay, ACTH followed by vigabatrin. Dravet syndrome is not really that common. However, this one occurs during infancy. There is severe myoclonic activity, no? So big muscle groups are affected. Okay? So the first line anti-epileptic drug here is valproate plus a benzodiazepine. For benign myoclonic epilepsy, valproic acid also is being recommended as the first line drug. For partial and secondary generalized tonic and clonic seizures, again, first in the for maintenance is oxcarbazepine followed by levetiracetam. You know this may be as Keppra. Okay, there are newer brands in the market right now, but of course levetiracetam is the generic name for that. Carbamazepine followed by valproic acid, and these are the alternative drugs. Now we move on to reviewing the type of febrile seizure. Remember, febrile seizure usually affects the age range 6 months to 6 years old. Madaling tandaan, 6 months to 6 years old. I always assure the parents, when they're past 6 years old, it's usually controlled. They don't have this febrile type of seizure. If seizure happens, beyond 6 years old and at the height of the fever, then you could be dealing with other entities such as, of course, CNS infection. Okay? But if they are 6 months to 6 years old, has a strong family history of febrile seizure, either parent when they were young also. So I always ask, do you know, has your parents told you, ikaw, mommy, daddy, that when you were this age, you had febrile seizure as well? Then I explained because there is inheritance of this particular condition. And then one more, number 3. If you do your GCS scoring, you assess that, you do your neurologic PE, what's your finding? Normal. No neurologic deficit. If you do your EEG, normal. Okay, so just assure them. So we control the fever. If there's no fever, there would be no seizures. For this entity, we investigate what is causing the fever. In young children, 6 months to 6 years old, overall, of course, you're dealing with viral infections. It could be, there's a case of maybe presumptive UTI that could be presenting again with high fever. So you need to investigate, meaning when we manage them at the ER or even at the OPD, we basically would request for CBC, urinalysis, depending on the accompanying signs and symptoms. Maybe there's respiratory tract involvement, maybe upper or lower respiratory. Kung lower respiratory tract, then we would request definitely for chest x-ray, especially if there are abnormal breath sounds during auscultation of the lungs. Okay? So that would be the approach for febrile seizure. But then again, the simple one is that the majority of which is simple type. It's generalized, it occurs less than 15 minutes, and it should not recur in the next 24 hours. Again, there are absent focal signs during the post-ictal period. The other type, of course, is complex febrile seizure, wherein it's more of focal. The seizures are more of focal, more than 15 minutes, and of course, it recurs in the first 24 hours. So, yung mga sasabihin sa STEM question in the board exam, the patient was noted to have seizures at home, okay, lasting for about 5 minutes. They brought the patient to the ER. While at the ER, the symptoms recur, the seizures recur. Okay? Kung pasok siya dun sa criteria ng febrile seizure, then if it recurs, then that is complex febrile seizure. Okay? And of course, for febrile seizures, very actively, like when they arrive at the ER, of course, your first line or the drug of choice for that is your fast onset, short-acting diazepam. It's still diazepam. The dose is 0.2 to 0.5 milligram per kilo per dose. So that's what we give. And then we expect response from diazepam within the first 3 to 5 minutes. We reassess if there is a need to give a second dose of diazepam because either the seizure persisted or the seizure has stopped but it recurred, making it complex febrile seizure. Then in the algorithm, of course, we can give a second dose of diazepam while in the ER. And of course, it will follow that we need to investigate the source of the fever. Okay? So for first febrile seizure guidelines, I'm just highlighting the 2011 guidelines here by the Child Neurology Society of the Philippines. Lumbar puncture should be performed in all patients below 18 months old for a first febrile seizure. So every toddler and infant below 18 months old, lumbar puncture is warranted. This is to identify other causes of the seizure happening during fever. As I said, of course, the most common one is CNS infection, your bacterial meningitis. For 18 months old and older, LP should be done in the presence of clinical signs of meningitis. What are the clinical signs of meningitis? Anong hahanapin nyo sa STEM question? Of course, signs of increased intracranial pressure. In a toddler, in an infant, ano yun? Headache, vomiting. Headache, of course, cannot be readily elicited in a toddler. So, how can they express that there is headache in a toddler? irritability, crying a lot, inconsolable crying, no? Ang hirap patahanin. What else? During physical exam, if the fontanelle is still open, remember the anterior fontanelle is open until about 12 to 18 months old. So let's say your patient is already 16 months old, first febrile seizure, and then you appreciated during palpation, there is still open anterior fontanelle. You have to determine whether it is flat, which is normal, or tensed or bulging. No? You will feel that because the palpating finger here would feel na para siyang nakatambok o nakaumbok. No? If it's bulging or very tense. So put them all together, you have a probable increased intracranial pressure in the context of having vomiting, persistent, unable to feed, and then again, poor level of consciousness. So, of course, the normal one is alert and awake, but then if they become irritable, and then down the line, they become lethargic, they become stuporous, of course, that's deterioration of sensorium. Okay? What else? In these guidelines, neuroimaging studies should not be routinely done in children for a first simple febrile seizure. Hindi routine na magpapa-EEG tayo agad-agad, no? And even neuroimaging, I'm talking about MRI, no? Children who had febrile seizures have increased odds of developing epilepsy. That's about 2 to 7%. Moreover, the use of continuous anticonvulsants is not recommended in children after a first episode of febrile seizure. We don't give maintenance medication for that. The use of intermittent anticonvulsants, whether diazepam or phenobarbital, is not recommended also for the prevention of recurrent febrile seizures. Let's say, okay, established na fulfill niya yung criteria ng febrile seizure. But if let's say may ma-encounter kayong question, ano ang part ng management nito na mali or incorrect? Okay? So kung meron dyan nakalagay na kailangan merong intermittent na anticonvulsants, then that is not recommended. It is not part of the overall management of recurrent febrile seizures. EEG also should not be routinely requested for in children with the first simple febrile seizure. Bottom line, if this is really a febrile seizure, whether simple or complex, then as long as they fulfill that criteria, your neuroimaging as well as EEG are not really part of the initial management, plus the giving of your maintenance meds or your anticonvulsants as maintenance meds. We need to explore and investigate the cause of the fever and then reassure the parents that this is what we call febrile seizure. But it's, of course, a different thing if they undergo status epilepticus. It was defined as a continuous seizure activity or recurrent seizure activity without regaining consciousness, lasting for more than 15 minutes. And this has been a part of an operational definition by the experts. And in Nelson, in textbook of pediatrics, the algorithm, the management, okay, the algorithm to manage status epilepticus would involve, of course, initial and emergent therapy by giving diazepam. By the way, what are the modes of administration for diazepam when you're dealing with someone who has active seizures? Of course, the first one is IV. But then again, remember, when they have, let's say, clonic activities or clonic seizure type, di ba? Yung jerky movements, that's clonic. It would be a challenge for the doctor to establish a peripheral line because of the jerky movements of the extremities. So if you are having a hard time establishing an IV, okay, the way to give your diazepam is sub-Q, intranasal, IM, rectal. Sub-Q and IMX. Pangit ang absorption ng diazepam. IV talaga. Lalo na oral, hindi. Kasi nga, kung nagsisizure yan, pangit ang sensorium. Intranasal, no? Definitely. So, rectal. Okay? So, what we do is the computed dose, 0.2 to 0.5 milligram per kilo per dose. So, weight times, I usually give it at 0.5 agad. Weight times 0.5 milligram per kilo per dose. That amount in a tuberculin syringe, 1 cc syringe, and then I ask the nurse to administer it slowly sa may puwet, sa rectal area. Okay? Make sure the needle is removed from the tuberculin syringe. Hindi natin gustong matusok ang puwet ng mga bata. Okay? So again, following the algorithm, short-acting, fast-onset anticonvulsant first. That's your diazepam. In some institutions, they don't have diaz. They may have lorazepam or midazolam. But then again, diazepam talaga, no, ideally. Again, when they reach first 15 minutes, naka 2 doses, wala pa rin, you can now give your long-acting anticonvulsant. That's phenytoin or phenobarbital. Both medications are given at 20 milligram per kilo per dose. Again, simple multiplication, 20 times the weight. So if the patient is like 20 kilos, 20 times 20, 400 milligrams IV. Loading dose, usually, ideally, 1 milligram per kilo per minute. Okay? So, phenytoin or phenobarbital. And then, pag wala pa rin, dun sa next sa algorithm, valproic acid na. And then, of course, the last one would be, if the status epilepticus na nga so hard to control, wala pa rin, then we definitely would give levetiracetam for that. Let me present to you this case. Okay? Ito pala ang tips ko rin, Sometimes you will encounter in the board exam, especially for clinical subjects, long cases. Sometimes, what you do, that my tip is, you focus first on what is being asked. In the few seconds that you are looking at this, don't be derailed. Don't panic. Don't be anxious. Just focus on what is being asked. In this case, the diagnosis. It may be long, but you need to learn how to pick up the key points, the key data that will lead you to the correct answer. Okay? So this one is a 5-year-old male. So you're dealing with a child during childhood. Okay? Presenting to the ED in the emergency department with a single episode of seizure, generalized tonic-clonic, lasting less than a minute. So a week prior, so you consider whether the case is acute or chronic. It's a week prior, so this is acute with a fever of 38, with dry cough, headache, irritability, and malaise, dismissed as flu. There was history of chronic cough for 4 weeks. Data like this, which points to a chronic condition of cough, makes you think that there is something wrong with the respiratory system. It's been there for 4 weeks without any consultation. And now, the patient presents to you with a depressed sensorium, being lethargic, with neck rigidity. No other neurodeficits were observed. There's additional, then you can go on, of course, reading the STEM question. Sometimes the examiner would give certain laboratory test results which you need to be familiar with, of course. For chest x-ray, having hilar adenopathies, what is its implication? It could be either of course, infection, but what kind of infection? If it's more of hilar, then somehow you think of chronic cough, hilar adenopathies, something chronic. Pinaka-common sa Pilipino, TB. Okay? Lumbar puncture, showed WBC of 200 with lymphocyte predominance, glucose of 30, protein is 1,000. So the key here is remembering how to interpret lumbar puncture results. Okay? So if you have more of lymphocytes, okay, glucose is that's low, protein is high, definitely. If you recall the expected findings in the CSF analysis, in meningitis, okay, or in infections in general, if you have a high protein and a low sugar, then in general you are dealing with bacterial type of infection. Again, high protein, low sugar, meron kang WBCs. Going back to this, definitely there's infection. Okay? So magkakatalo na lang, okay, testmanship. Are you dealing with bacterial o viral. Okay? Again, this is bacterial, so out na yung B at saka C. Kung aseptic kasi, dapat walang WBC, but there are WBC seen here. So you're left with bacterial or TB. What's your answer? Because there is chronicity of the presentation, most likely you are dealing with TB meningitis. Okay? Compare that particular case to this one, the same 5-year-old male coming in for confusion and lethargy a week prior, so that's somehow acute again, low-grade fever, cough, headache, irritability, and malaise, no treatment. Patient is now lethargic, pangit na rin ang sensorium, and then you still have a high-grade fever, although the heart rate and RR, they're negligible, but there's nuchal rigidity, no vomiting, and no other neurologic deficits. So lumbar puncture again revealed WBC. This time, it's much higher at 2,000 with neutrophil predominance. Glucose 20, that's again low. Protein is again high. So put them all together again. In general, kasi di ba TB definitely is bacteria din naman, no? Kaya lang yung chronicity, you tend to entertain more of TB etiology for meningitis. But this one clearly is a classic presentation of, in general, bacterial meningitis. Okay? For bacterial meningitis in the pediatric age group, I want you to remember the etiologic organisms. Do you remember? For infants and young children meaning less than 5 years old, 5 and less than 5 years old, number 1 still would be, you are right, strep pneumoniae, followed by Hib, H. influenza B. And then number 3, etiologic organism for bacterial men, Neisseria meningitidis, SHN, strep pneumo, Hib, Neisseria meningitidis. Which brings me to my next point. Very important during history taking, ask them, what is the immunization status for all of this? Meron ba siyang pneumococcal vaccine during infancy? 3 shots. How about the booster shots beyond the first year of life? If they are availing of the primary series, refer to the first 3 shots during infancy. If they are availing the primary shots in a health center, well and good. But the thing is, the vaccines available there are only being given during the first year of life. Beyond that, we know that there are booster shots, or we re-enhance the prior protection that was given during infancy. Wala na. But if they are availing of all of these vaccines in a private clinic, in a private practitioner, yes, well and good. Most likely meron sila. Okay? But again, we do not presume. That's why we ask. We ask always during history taking, may booster shots ba ng lahat ng ito? Okay? So yes, going back, this is more a picture of bacterial meningitis. And then, I just like to show you as a review this table lifted from Nelson Textbook of Pediatrics. So let's start with the normal first regarding CSF findings. Normal is, of course, when you do the pressure, when you measure this, it's 50 to 80 millimeters water. For leukocytes, it should be less than 5. Protein, it's a range between 20 to 45 milligrams per DL. Remember, yung isang example kanina, 1,000 milligrams, so masyadong mataas yun. The other example is 500 milligrams. So again, that's too high a CSF protein value. Glucose is normal, should be more than 50 or 75% of the serum glucose, which means that when you analyze, when you interpret the CSF glucose, you should also have a serum glucose level sa blood in order to differentiate and see the difference. Basically between the serum and the CSF glucose level. So again, these are the normal values that you expect. So just to re-emphasize again, for bacterial meningitis, everything is high. Lahat mataas. Mataas ang pressure, maraming leukocytes, madami yan, no? Mataas. Protein is high, 100 to 500. Decreased glucose. Okay? For partially treated bacterial meningitis, ibig sabihin, common scenario, patients who will be transferred to hospital of choice. Let's say, Parents, for some reason, wanted to be transferred to another institution, but the first institution which is taking care of this patient has already started treatment for bacterial meningitis. Say, for the past 2 days, 48 hours na siyang naka IV meds for CNS infection. And then, to be transferred to another hospital, since there is already initiation of the IV antibiotics, if the new institution will repeat the lumbar tap of this patient, theoretically, it is to be expected that the findings there would be of partially treated bacterial meron na siya 48 hours na siyang naka-medication. So the pressure may now be normal. Leukocytes is still there, but maybe a little low. Protein is still there, and then glucose is normal to decreased. Okay? Viral meningitis or meningoencephalitis, with regards to pressure, it's normal or just slightly elevated. They have rarely more than 1,000 cells. Okay, so more of lymphocytic siya. Protein is 50 to 200. It is still high but not as high as when it is bacterial in etiology. And glucose is generally normal in viral men. Tandaan, pag bacterial, baksak ang glucose. Why is there glycorrhea or low CSF glucose level? Naalala nyo yung, ewan ko kung naabutan nyo yun. But some of the practitioners would say, kasi kinakain nung bacteria yung glucose. Parang Pac-Man, kinakain niya. Pero hindi. So the decreased glucose is due to glycolysis by both white cells and the pathogen. And because there is impaired CSF glucose transport. Kaya hindi umaabot, kaya mababa lang yung level niya. Okay? So hindi dahil sa kinakain-kain siya. Na parang ng mga bacteria. For tuberculous meningitis, again, TB, no, Mycobacterium TB. So again, expect that there is elevated pressure, 10 to 500 cells, really high protein, and then low glucose as well. And then you may see acid-fast organisms. So, halimbawa, highly suspecting kayo na ang meningitis niya secondary to TB. Another bottle, if you are doing the lumbar tap, another bottle is to be collected and to be specifically tested for AFB. Okay, so CSF, presence of AFB. Okay. Now, can we do blood culture instead of LP? No, for some reason, let's say that the patient is in a resource challenged institution, hindi available agad, send out pa sa ibang hospital. Yes, you may do blood culture. Why? Because it reveals the responsible bacteria in up to 80 to 90% of cases of meningitis. Tandaan, hematogenously spread ang meningitis. So yes, there's a good chance, a high likelihood of identifying the bacteria if you do blood culture. Now, what if the lumbar puncture is traumatic? Diba? Yung bloody, yung lumalabas, bloody tap kung tawagin. Experts say it is still prudent to rely on bacteriologic results because the gram stain, culture, and glucose level may not be influenced by a traumatic LP. In fact, there is a corrective formula to do that. No? But that is beyond the scope now of the review. Is there a difference, or will there be much difference if the child was already started on oral antibiotics prior to LP? The presumptive diagnosis of bacterial meningitis can be made despite negative cultures because a high level of cells, that's your pleocytosis, high CSF protein level, and low sugar persist for several days even after antibiotics. So okay lang. Now, to mention the clinical practice guidelines on acute bacterial meningitis, this is from Philippine Pediatrics Society as well as Pediatric Infectious Disease Society of the Philippines. That's PIDSP back in 2015. It hasn't been upgraded yet or revised yet, but it still consistently tells us or recommends that the signs and symptoms associated with neutrophilia and increased CRP, that's your C-reactive protein, are highly suggestive of bacterial men. In other words, pag tinanong kayo sa STEM question, ano pa ang mga ibang laboratory tests that will help you determine presence of bacterial men? Yes, CRP would be that answer, increased CRP. Your procalcitonin, yes, it is still used, but it may be used to differentiate viral from bacterial men. But in situations wherein a CSF analysis cannot be performed immediately, it may be used as a basis to start antibiotics. But it should not replace CSF analysis and culture to diagnose bacterial men. Yes, it may help, but it should not replace CSF analysis and culture. What to watch out for with regards to complications of bacterial meningitis? This is just a mnemonic. Maybe you are into mnemonics. Some of the students or learners are not so much into using mnemonics, but whatever it is, to your pleasure, with regards to how to remember some of the important points, no, in a certain condition. Okay, so regarding complications of bacterial meningitis, you have hydrocephalus. We watch out for abscess, brain abscess, cerebritis or cranial nerve involvement, thrombosis, infarct, ventriculitis, and empyema. That would be extraaxial fluid collection. And how to recognize that there are complications of bacterial men, most useful would be an MRI of the brain rather than CT scan. Now, have you seen this kind of neurologic problem? It's again one of those important CNS infections that need to be identified ASAP. Okay, have you seen one? This particular condition has this presentation. Typically, they would occur 1 to 2 days, very acute. 1 to 2 days having fever, moderate to high grade. And then the patient would initially rush the patient or bring the patient to the ED because there is quick deterioration of the sensorium. The common history, they would tell us, kahapon po, kagabi lang, okay po siya, naglalaro kahit mataas yung lagnat. Pero ngayon pong hapon, okay, the following day, parang ang hirap niyang gisingin. Okay? So, increased sleeping time. So, that of course, obviously, is being lethargic. Okay? So, with regards to the rashes that you see during physical exam, of course, part of our history, sasabihin natin, kailan pa po yan? Kahapon po, pinpoint lang. Pero ngayong hapon po, ganito na. Okay? I know that you are thinking of highly infectious CNS infection. Of course, you're thinking of meningococcemia. So, Neisseria meningitidis, this is transmitted by droplets or through contact with respiratory secretions. And they're considered highly infectious until 24 hours after initiating effective treatment. Incubation period is wide, 1 to 10 days, but give or take, it's about 4 to 5 days na incubation, no? Exposure to the organism prior to the appearance of the symptoms. The thing is, it also has a wide spectrum with regards to manifestations. The patient can have asymptomatic colonization to having the worst, fulminant sepsis. It's not only the brain that may be affected, but there could also be infections of the genitourinary tract, conjunctiva, pharynx, CNS, heart, skin, adrenals. Actually, multi-organ siya, no? And if that happens, especially if it has affected the adrenals, then there would be shutdown of the kidneys as well. If they have diffuse adrenal hemorrhage with or without vasculitis, then that is what they call Waterhouse-Friderichsen syndrome. Then they may go into DIC, coma, and death. The thing is, okay, the important thing to remember also with the meningococcemia is that seizures and focal neurologic signs occur less frequently than in patients with meningitis due to Hib and pneumococcus. So, what again are the pertinent features of meningococcemia? Kasi hindi common ng seizures. Okay? Hindi common. Okay? You rely on the presence of the acute onset of fever, the quick deterioration of sensorium, from 1 to 3 days or 2 days from the onset of the illness. And of course, the appearance of petechia evolving into becoming purpura, mas malaki sa petechia, and of course, mas malaki pa doon, ecchymosis, all happening in the next 48 to 72 hours. That's how fast it is. Less common na nagsi-seizure ang pasyente sa meningococcemia. Mas common yung seizure sa pneumococcal meningitis tsaka sa Hib meningitis. Going back to meningococcemia, what then is your drug of choice? Okay. In Nelson, again, you could give penicillin G in 4 to 6 divided doses for at least 5 to 7 days. Or if you have ceftriaxone in the hospital, yes, we do give your third generation cephalosporin or cefotaxime. They have very good penetration to the blood-brain barriers and expect clinical improvement within 24 to 72 hours. Dapat to, quick thinking, high index of suspicion, especially if you have acute onset of fever, deterioration of sensorium, appearance of rashes, petechia, becoming purpura, becoming ecchymosis. That's it. That's meningococcemia. And this is lifted again from Nelson, textbook of pediatrics. You see here all the accepted drugs of choice for Neisseria meningitidis mentioned earlier. Now, there are, like in the face of life-threatening beta-lactam allergy, talagang merong napatunayan na allergy dito sa mga drugs of choice na ito. The alternative drugs for Neisseria meningitidis would be chloramphenicol IV or ciprofloxacin or meropenem. These are the alternative drugs for treating meningococcemia. How about those exposed? Household, school, or daycare contacts during the 7 days before onset of illness should receive antibiotic prophylaxis. So prophylaxis is not routinely recommended for medical personnel except those with intimate exposure. Halimbawa, ikaw talaga yung first contact doctor dun sa ER na na-meet yung pasyente. Regardless whether you have, it's very good if you're wearing N95. At least no one is wearing PPE nowadays, no? Pero kami, no, sa ER, ako, naka-N95 pa rin kami. Regardless if you're wearing N95, at least alam mo na meron kang protection. But still, kung na-intubate mo yung pasyente because of decreased sensorium, baksak ang GCS, nag-suction ka, who does mouth-to-mouth resuscitation nowadays? No, not that one. But these are just, just to emphasize what is intimate exposure with the patient. Sila ang nangangailangan ng post-exposure prophylaxis. And what do you give these persons? Especially those in the home, in the household. Okay? For children who were already exposed, the other siblings maybe, rifampicin, 10 mg per kilo per orem every 12 hours for a total of 4 doses. Okay? And this is for 2 days. Or we could give a single dose intramuscular ceftriaxone for less than 12 years old. So this is an alternative. And for us, adults who got exposed, very intimate with them, ciprofloxacin 500 milligrams per orem as a single dose. So that is all for meningococcemia. Let me go to neural tube defects. So what is the underlying cause? Again, there is failure of the neural tube to close spontaneously between the 3rd and 4th week of in utero development. And there's a long list of etiologies why there is neural tube defect. Hyperthermia, drugs, malnutrition, chemicals, or even maternal obesity or diabetes, genetic determinants would adversely affect the CNS development even from the time of conception, and you know that. And the most severe form of neural tube defect or dystrophism is what we call myelomeningocele. Actually, during initial physical exam of newborns, isn't it that, of course, when they are undressed, okay, we do the physical exam after unang yakap, di ba? Yung nakalagay sila dito sa chest ni mommy and everything. After which, kapag na-stabilize sila, we do the first PE, the first very, very comprehensive PE. We could easily identify if there is a mass. Usually, this is described as erythematous, sometimes with a cover, sometimes there's no cover, sometimes it's just a tuft of hair along the lumbosacral area. Okay, and you could see that they're protruding or jutting out from the back, from the lower back, and that is your myelomeningocele. How can this be prevented? Of course, maternal periconceptual use of folic acid to reduce the incidence by at least 50%. And kailan magsa-start ang folic acid? Started before conception until at least the 12th week of gestation when urolation is already complete. We give it at 0.4 milligrams once a day. Otherwise, if they do develop myelomeningocele and the other neural tube defects, you expect manifestations that are secondary to dysfunction of the skeletal, skin, GUT, peripheral, and central nervous systems. Again, the most common location of this myelomeningocele, 75% of which appear along the lumbosacral area. So something like this. Okay, so here, if you focus your eyes on the right-hand side of the slide, your spina bifida or your neural tube defects, to, no? Minsan may covering, minsan wala. Ito yon, no? Okay, nakaumbok sila. No? Ito, this one. Grossly, makikita nyo talaga yung lesion na nandun. Okay? Manifestations, check the DTRs, okay, the deep tendon reflexes of these babies. The DTRs are absent. You have flaccid paralysis of the lower extremities. They lack response to pain and touch. They may have hip subluxation, club feet, or talipes equinovarus. Bowel and bladder incontinence, so walang control, di ba, sa wiwi. At saka you check the sphincteric tone, whether it is good. If it is tight, so that's normal, that's good. But if it is lax, then you may have problems with regards to sphincter control. And also with myelomeningocele, they are associated with hydrocephalus or type 2 Chiari. Yung type 2 Chiari malformation, it is more severe compared to type 1. Less common but more severe and almost always associated with myelomeningocele. It involves yung type 2 caudal displacement of the lower brainstem. For Chiari type 1, okay, na malformation, again, it is more common but least severe. This time, in this type, you have caudal displacement of the cerebellar tonsils below the foramen magnum. Now we proceed to headache. Quite commonly, especially during the pandemic, no, the height of the pandemic, patients would be rushed into the ER because of very severe headache, and this has been because of number one reason is actually psychological, and of course underlying neuro na talaga nagma-migraine, pero the precipitating factors for that has been largely associated with the feeling of the fear of the unknown cooped up in their household, bawal lumabas, 'di ba? Ganun tayo noon like 3 years ago. So, yes, there is migraine in childhood. And what are the features again? It is recurrent with symptom-free intervals and at least 3 of the following. So, at least you have to identify at least 3 of the following. There's positive family history, very easy to ask the parent. And then there is relief following sleep, usually one-sided in the location, associated aura, there's abdominal pain, nausea and vomiting, and throbbing in character. If you fulfill 3 out of this, then yes, you might be dealing with migraine headache. But when do you request for imaging studies? Indications for cranial CT scan, not all of them pero kapag abnormal ang neurologic signs, meron ka talagang neurologic deficit, may one-sided or left-sided or right-sided weakness, then that's very alarming and definitely would warrant cranial CT scan. If there are behavioral changes or recent school failure or falling off in the linear growth rate, and that is when you plot the height and you see that there is deceleration of the height. Headache awakens the child during sleep, that's very bad. Migraine and seizures occurring in the same episode, focal signs and cluster headaches, yes, any of these definitely they would need to undergo cranial scan. So the treatment, you will ask, what is the drug of choice in pediatric patients? It's still acetaminophen or paracetamol or ibuprofen. Just make sure that there's no NSAID allergy. So it's still acetaminophen or ibuprofen or antiemetics, no? Kasi 'di ba associated with vomiting. But we do parenteral metoclopramide, but we don't routinely give this unless there's really persistent vomiting associated with migraine headache. There's such a thing as status migrainosus, wherein this is the worst type, wherein there's persistent headache lasting for more than 3 days. In the Western countries, they do give prochlorperazine, but we don't have this. Prochlorperazine in pharma, if you remember, this is a dopamine receptor antagonist that belongs to the phenothiazine class of antipsychotic agents. But when they use this, they are after the antiemetic treatment of nausea here. And parents again might ask you, when do we give prophylactic therapy? Okay? If there have been more than 2 to 4 severe episodes monthly, unable to attend school regularly, and it is useful if you use the it's a screening test called Pediatric Migraine Disability Assessment or PEDMIDAS score. Okay, so if the patient scores higher than 20, then that is the signal that they need to have prophylactic therapy for migraine. And the drugs of choice for prophylaxis is propranolol. Again, make sure that the patient has no asthma. We know that this is contraindicated with an obstructive lung problem. It's either propranolol or flunarizine, which is given at bedtime. Now, how to differentiate migraine headache from tension headache? Okay? You see this sort of Venn-like diagram, no? So definitely the two would, of course, there's pain, even mild to moderate. However, for migraine type of headache, very prominent would be the presence of nausea and or vomiting. And as I said earlier, the throbbing pain. The pain could really be moderate to severe in some cases. It's unilateral. There's some aura before onset and sensitivity to light or sound. So meron silang photophobia, phonophobia. So ayaw nilang nakakarinig noon. Gusto nila dim ang light ng kwarto. Okay? Compared to tension headache, it is described more as having a dull pain or a tight pain na para daw merong band-like tightness. Parang may nakapalibot na pain from the glabella around the occiput. Band-like tightness. Distracting pain. And I will add to this. This is usually most prominent yung tension headache toward the end of the day. Yung mga sinusugod sa ER sa amin ng mga childhood age, mga 6 to 9 years old, and even adolescents, pagkatapos ng school na, tapos usually tinatanong ko, what were you doing before? Ang mga top question or top answers nila sa akin is, it's been a long day, napuyat ako, okay? O kaya hindi ko natapos yung long exam, so I'm having this headache now, hindi na kinaya matapos, or I'm trying to beat a deadline kasi maraming mga requirements. So yung mga ganun, no, usually yan, tension headache, especially towards the end of the day. Okay, let's look at this STEM question. A 10-year-old boy presenting with progressive weakness in both legs that started 5 days prior to consultation. He just recovered from an ORTI about 2.5 weeks prior to consultation, but on the day of consultation, he could not walk independently. His neuro exam showed absence of patellar and Achilles tendon reflexes bilaterally. Okay? So, ang tinatanong dito, what is the expected CSF finding? So, two-step analysis sa isip ng isang examinee, no? Tinatanong kayo ng expected laboratory test finding. Pero bago nyo masagot yon, you should have formulated in your mind at least an initial diagnosis. So what comes to mind, if there is a child that has recovered from a viral illness 2 weeks ago, but now the prominent manifestation is weakness in the legs and apparently could not walk anymore, and ascending paralysis, that's another term to describe this condition. Ascending paralysis or ascending weakness, okay? And then absent reflexes. If you're thinking of GBS, Guillain-Barré syndrome, you are correct. And part of the diagnostics of this is, of course, having a CSF finding, and the expected result would be letter A, increased protein. The rest of the parameters are normal. Okay, let's take a look at GBS once again. This is acute demyelinating polyradiculoneuropathy. Symmetric ascending muscle weakness or paralysis is the way to describe it. So the etiology, experts say this is autoimmune reaction that develops in response to a previous infection. So very important is to ask, go back in the history, what has been the other illnesses of this patient? And true enough, you will be able to elicit like 2 to 3 weeks prior, there has been either a respiratory illness or a gastrointestinal illness. In Nelson, for GI infection prior to GBS, in Nelson, it is mentioned that very important is a prior Campylobacter infection, no? GI infection, specifically due to Campylobacter. So what happens? This autoimmune reaction would lead to aberrant demyelination of peripheral nerves and ventral motor nerve roots. So post-infectious na to, no? But again, it involves the motor function. It is not hereditary. Obviously, it's post-viral or post-bacterial and affects all ages. And as I said, if GI, you could be dealing with the Campylobacter infection. I'd like to highlight that the weakness begins in the lower extremities and progressively involves the trunk, upper limbs, and the bulbar muscle. So, delikado pag pumapanik. Kasi pag once na affected ang diaphragm, you know that the breathing and the respiration definitely would be compromised. What are the other physical findings associated with this? Look for involvement of the cranial nerves. So if you have deficits there like dysphagia, dysarthria, yung mga difficulty in articulation, no? Facial weakness, papil edema, autonomic dysfunction, and respiratory muscle paralysis. Okay, so these are all possible manifestations. And there's a syndrome, there's a variant for this. Aside from the progression of the weakness, no, ascending weakness, if this also involves acute ophthalmoplegia, ataxia, or incoordination, pangit ang balance, areflexia, walang reflexes, then that is Miller-Fisher syndrome, part of the GBS. Okay? Kung may involvement ng ganito, ophthalmoplegia, ataxia, and areflexia. So the tendon reflexes usually are the last function to recover, and lower extremity weakness are the last to resolve. Benign naman siya with spontaneous recovery, kaya lang it takes time, 2 to 3 weeks. However, 3 clinical features are predictive of a poor outcome. Poor prognosis kapag meron ka na talagang cranial nerve involvement. The patient was intubated along the way, along the course of the illness, and there's maximum disability at the time of presentation. So, poor outcome yung mga yan. In the question earlier, we asked what is the peculiar or the distinctive result when you do a lumbar tap. Expect increased protein, normal glucose, no cells or no pleocytosis. And you call it albuminocytologic dissociation, wherein there is a high, very high protein but a lack of cells found in the CSF. And of course, they would be treated with IVIG. Okay? This is given for 5 consecutive days, and we could offer to give high-dose steroids or pulse therapy for relapses. And that is for GBS. And I believe that is the last portion for the review for pediatric neurology. Now we proceed to review of pediatric pulmonology cases. Okay, so cases that might be presented or asked during the exam would definitely revolve around symptoms like cough and difficulty of breathing as well. So the approach to cough is, of course, when you look at the STEM questions, try to identify again, is the onset of cough acute, chronic? Are you dealing with wet cough, also known as productive cough? Or is it dry or non-productive? How about the timing? Take note. Look for the words in the STEM question. Is it more of daytime? No predilection at all? Or are you dealing with nighttime coughing? And I know that you already have a preconceived idea or notion about having nighttime cough. Of course, that would be asthma. And what about associated symptoms? Fever, colds, watery and or itchy eyes and rashes. For the physical examination, definitely again, during while you read the STEM question, look at the RR for you to identify whether it is normal or fast or even slow. You have to be familiar with the normal range of RR per age group and look at the given autosaturation level. Of course, we're aiming for 95% and above at room air. And then, the very important signs of distress. Did the STEM question mention anything about alar flaring, retractions, the abnormal breath sounds? How about inability to drink? And the presence of cyanosis. All of this again would definitely more and more additional findings like this, of course, point to a very severe type of respiratory illness. Now, this portion is lifted from PALS, no? The Pediatric Advanced Life Support, which I think is very important in trying to categorize everything in terms of trying to identify the respiratory condition. So, when you're dealing with respiratory problems, you have to identify whether that patient is within the spectrum of having distress or is this already failure, respiratory failure. If they are in distress, usually you would note that there is a very fast respiratory rate for age. And how about the effort? When you say effort, there is increased work of breathing. So meaning there is nasal flaring, retractions, use of accessory muscles. Maybe if the problem is having inadequate effort, then what you will see in the patient is hypoventilation and will be described in the exam as having bradypnea. And of course, the change in the airway sounds as well as having pallor or cyanosis and a change in mental status or a deterioration of the mental status. When you identify someone who has this, and then there is already intervention to at least stabilize the patient, if the primary intervention or the preliminary therapeutic modes were already given to the patient and yet there is no response or even deterioration of the clinical state wherein there is now inadequate oxygenation, ventilation, or both, despite the initial emergency stabilizing measures, then you might be dealing with the end stage of respiratory distress, meaning the patient is now going into respiratory failure, wherein there could be bradypnea, initially having tachypnea but now having bradypnea, no respiratory effort at all, poor to absent distal air movement, bradycardia, cyanosis, and of course being stuporous and worse being comatose, then you are looking at someone who already has respiratory failure. Let's try to identify the problems one by one. First, are we dealing with signs of upper airway obstruction? You can see here that the common conditions would be either croup, foreign body aspiration, or anaphylaxis. And that again is under the first problem, upper airway obstruction. So in general, you have increased rate and effort here, a change in voice. Very particular here is the presence of stridor. What is stridor again? It's a musical sound mainly heard during inspiratory phase and associated with upper airway obstruction. Okay? And there could be also poor chest rise, poor air entry, as well as drooling, snoring, or gurgling sounds. And very typical of the problem of upper airway obstruction is what we call LTB, laryngotracheobronchitis, also known as croup. The most common etiology is para-influenza virus. Alam nyo, just last Thursday night, so I was on duty at the ER. So there's this exactly 1-year-old, a 12-month-old boy coming in for 2-day history of fever, cough, and colds. Pasok na pasok, diba? They're always like that, fever, cough, colds. Actually, the patient was already seen Wednesday morning in the same ER. Another colleague of mine. So in the ER, we are able to review all the entries there for every person who comes in there because of the of course the electronic medical records, the EMR. So as I was going through the EMRs, nakita ko doon the patient was eventually sent home because the onset of the fever cough colds was just on that day. Dinala lang agad sa ER kasi nagwo-worry yung father. Okay? So, apparently, the patient was managed as viral infection and there's no signs of distress. But the interval history is very important. They arrived, they got home after being discharged at around 1 p.m. Wednesday, but they noted that from 1 p.m. of Wednesday up to Thursday night, so that's about more than 24 hours, or maybe 24 plus 10, 34 hours. Interval history ang mahalaga. Nag-deteriorate. Nag-deteriorate siya. Ang sabi ng father, Doc, naririnig ko siya na merong musical sound. Ano po kahit po siya gising or tulog, merong siyang tunog. So, theoretically, una kong naisip stridor, tapos narinig ko siyang umubo. The patient came in with an RR of 48 per minute. 12 months old. Fast, low, normal. 12 months. If you recall, up to 12 months old, less than 50. So kung tutuusin, technically, normal pa. Pero medyo on the high side. You get what I mean? It's 48 breaths per minute for a 12-month-old. Okay? Considered na less than 50 siya, normal. But overall interpretation, I saw the patient with alar flaring, deep suprasternal retractions, as well as deep subcostal retractions, and there is prolonged expiratory phase. When there is prolonged expiratory phase, you think of obstruction. Ang pagtatalunan na lang upper airway, lower airway. But when the father said, okay, there's stridor, tapos narinig kong umuubo, remember, croup is a clinical diagnosis. So I immediately regarded the overall condition. Oh, this is croup. Okay. So what do you do? Especially if the patient has now signs of severe distress, alar flaring, cyanotic lips, stridor, barking cough, prolonged expiratory phase. Of course, you give your oxygen support. The O2 sat of this patient at room air was 80%. So when we administered oxygen via nasal cannula, maximum of nasal cannula is 4 liters per minute. True enough, thank God, tumaas. Okay, naging 98% with oxygen support. But still, the patient is in distress. But having known that this is now, viral group, having known all the presence of the stridor and the barking cough, I follow the algorithm, the guidelines for treatment of croup, which is giving remember, croup, inflammation of larynx, trachea, bronchi. You need to address the inflammation of the airways. So, in the guidelines, we give dexamethasone, your steroid, the anti-inflammatory medication, okay, to treat the edema of all these parts of the airways. And then you give for moderate to severe distress your nebulized epinephrine. Do you do your neck x-ray at once, ASAP? No. You address first the distress. Remember, being clinically diagnosed, this condition, you don't need to see the steeple sign for you to call it croup or for you to not call it croup. X-ray findings do not correlate well with disease severity. Kung makita nyo yung subglottic narrowing, well and good, bonus na yon. Halimbawa, hindi nyo nakita yung steeple sign sa neck X-ray, you would still be treating the patient as croup. Okay? Kasi nga, clinical diagnosis siya. So, bonus na lang. But, with this patient, nagpa-bedside kaming X-ray agad. It indeed showed the steeple sign. Okay? So, narrowed, pointed. Pointed talaga yung area ng subglottis niya. Okay? So, this one, we saw this actually in that patient, subglottic narrowing. So, as I said, if you say that the condition is diagnosed clinically, So you look for the signs of respiratory distress. I would like to remember this as CLARS. No? Maybe this could be a useful mnemonic for you, for those who are into mnemonics again. So C is for presence of cyanosis, L is level of consciousness. So the more severe the presentation of this sign, the worse the category of distress, obviously. So the patient back then presented as being lethargic. So alam mo nang in distress. Cyanosis, no? Putlang-putla, grayish na yung lips niya. Air entry, actually okay pa. Naririnig ko yung pag-inhale tsaka pag-exhale. Kaya lang may stridor talaga during inhale. But I still am able to hear, to appreciate the expiratory phase. Prolonged nga eh. Then retractions, I said that the patient presented with supraclavicular as well as subcostal retractions and the stridor. So all of these, put them all together again. The more signs, the more severe signs that you have, the more that it is croup. Okay? So, again, regardless of the severity, whether mild, moderate to severe, you need to give dexamethasone. This is to address the inflammation. 0.6 milligram per kilo per dose. If the patient has mild croup, ibig sabihin kaya pang makatolerate ng oral feeds, hindi siya takipnik. We give it per orem. We just crush or pulverize the tablet and mix it with about 75 ml of water. But of course, with that patient, moderate to severe, we gave Dexa IV, 0.6 milligram per kilo per dose. So I remember the patient's weight then was 9.5 kilos. So 9.5 times 0.6, it was about 5.7. So 5.7 milligrams. So that's about 6 milligrams of Dexa. Okay? So NPO temporarily, kasi syempre, no, hindi naman siya makakalunok, no? So baka mag-aspirate lang. The thing is, in PALS, Pediatric Advanced Life Support, ang nakalagay doon, racemic epinephrine. We don't have that here in the Philippines, but pharmacists and experts, pulmonologists have acknowledged the other alternative for giving nebulized epinephrine, and that is using the epinephrine in the vial, the one that we use for resuscitation. So yung vial na yon, okay, we mix it with 3 ml of NSS. So 0.5 ml per kilo per dose, maximum of 5 ml yon, to be mixed with 3 ml of NSS. And that is what we use to nebulize the patient. So thankfully, again, after intervention, you need to reassess. For every intervention, reassess after. After 15 minutes, talagang gumanda. As in gumanda, na-maintain, na-sustain niya yung O2 sat niya na nasa 98-100%. From being lethargic, naging much awake siya. Medyo irritable, but irritable is better than being lethargic. Okay? Pero dumilat na siya, no? And then, better ang air entry. Okay? So, we just needed to admit the patient for further monitoring in the intermediate care, because in our hospital, we have IMCU, intermediate care, one step lower than the ICU itself. Okay? So, this is one perfect example of managing your group, especially when they come in with distress. Again, please don't forget, if they have fever, cough, colds, they're usually like that, but then it deteriorates, it evolves into having stridor and barking cough, then call it croup. Okay? No matter, regardless whether you saw the steeple sign in the neck x-ray or not, it's croup. Especially if it's affecting 3 months to 3 years old. Again, the particular patient that I told you about was 1 year old. And then don't forget, majority of the condition is due to para-influenza virus. You have more of low-grade fever, barking cough, stridor, and then the steeple sign. To differentiate it from epiglottitis, the age group that's affected is more of 3 to 7 year old. And then you have HIB as the most common etiologic agent. Okay, but if the patient is vaccinated, okay, the common etiology is staph aureus. For unvaccinated children, the common etiology for epiglottitis is H. influenza B. Okay? So, they present more as having high-grade fever, muffled voice, drooling, and on the neck x-ray, what you will see is the thumbprint or the leaf sign. So again, the picture to your left is showing the subglottic narrowing here, the one being pointed by the laser, the red laser dot point. Here, on the right-hand side of the slide, the white arrow is pointing to the inflamed epiglottis, like that of a thumbprint, okay, or a leaf sign. Again, that is epiglottitis. Okay, so let me walk you through this table. Just to review, no, what you have are chest X-ray findings here of certain conditions that present with upper respiratory obstruction. So again, if you see patchy infiltrates and rugged tracheal air column, what do you think is the most likely diagnosis? So if you answered tracheitis, you are correct. This one is also just like epiglottitis. This one presents acutely with distress, okay, and with copious secretions, copious purulent secretions. Okay. For thumb sign, again, okay, you are correct. That's epiglottitis, subglottic narrowing. You know this as croup. If there's air trapping on the right lung with mediastinal shift towards the right lung, what do you think is the problem? If you say there could be foreign body airway obstruction, you are correct. So kung merong foreign body, okay, may ball valve mechanism yon, di ba? May air trapping yon. So, let's say nandun, air trapping sa right lung. Tapos may mediastinal shift siya towards the right lung din. Okay, so that's your upper airway obstruction. May atelectasis, at, T, toward the affected side. Okay, atelectasis. At T, that's the way I remember that. No, I try to recall that. Atelectasis, T towards the affected side, yung mag-shift yung mediastinal structures nyo. And of course, steeple sign is croup. Okay, so for the treatment, bacterial tracheitis is basically due to your bacterial etiology, Staph aureus. So definitely that's for admission and we give IV antibiotics. Epiglottitis, it is also due, as I said, if unvaccinated, Hib, if vaccinated, Staph aureus. Okay, so warranting again IV antibiotics. For croup, we already established that croup for all types of distress, whether mild, moderate, or severe, dexamethasone. But for moderate to severe, dexa plus epinephrine, okay, nebulized epinephrine. Foreign body, of course, is they have to undergo rigid bronchoscopy ASAP. Okay, this is another table here. Let's practice again. Patient presenting with sore or scratchy throat, so mesipon, nasal obstruction. What do you think is the most likely diagnosis? If there is prominent itching and sneezing. So nasal eosinophilia. Sneezing especially in the morning. So may eosinophils ka. So definitely most likely this is allergic rhinitis. What about there's colds but it's more of unilateral foul-smelling discharge and it became bloody toward the end, toward the ensuing days. Of course, alam natin to sa ENT. Foreign body, no, sa nasal cavity, lalo na pag unilateral foul-smelling discharge. What about may colds plus headache, facial pain, periorbital edema, and the colds has been there for more than 2 weeks. You know that viral colds is just like what, 5 to 7 days. But if it's there lingering for, reaching 2 weeks or even more, now developing also headache, facial pain, no? I would say in the PE, maybe maxillary tenderness or frontal here in the head, in the glabellar part, frontal headache. Yes, that's sinusitis already. You know that sinusitis is impaired mucociliary clearance coming from a viral colds that now has been complicated. That's why it has become acute sinusitis, no? And to diagnose this, aside from the typical manifestations mentioned this, you may want to do your paranasal sinus X-ray, wherein you might be able to appreciate their opacification, puro puti, no? Yung involved sinus. Let's say the maxillary sinus is opacified. Here maybe frontal sinus and then the ethmoid sinus. Remember, the first sinuses to be appreciated in the X-ray and to be aerated, ano yun? You might want to remember me. Me present at birth, ME. Maxillary and ethmoid. Okay? Ang next na aerate, sphenoid, around 4, 5 years old. The last to be really developed and aerated is frontal. That's around 6 to 7 years old. So, hindi common ang frontal sinusitis sa less than 5 years old. Kasi 6 to 7 pa lang siya na-aerate. Okay? But then again, if you have prolonged colds and now going into the second week of the illness, still with colds, fever, now with headache, facial pain, then yes, consider sinusitis. What are the top 3 etiologic agents for sinusitis? You may want to remember also as strep here. Strep yan. Strep. Followed by Hib. And then followed by Moraxella cataralis. Okay? That's for sinusitis. If you look at it closely, since we're dealing with upper airway, okay, or upper respiratory tract infections, sinusitis, again, common etiologies, strep pneumo, Hib, and Moraxella cataralis. These are the same 3 bacteriologic organisms causing otitis media. So, it's the same. Kasi diba magta-travel lang siya dito, hematogenous dito. So, kung meron din silang presentation naman of prolonged colds, okay, nasal congestion, fever, irritability, and of course, upon physical examination, loss of the cone of light, very tympanic, bulging, tympanic membrane, hyperemic or bulging tympanic membrane with loss of cone of light, then that again, of course, is your otitis media. The same organisms like sinusitis, strep pneumo, Hib, Moraxella cataralis. Okay? This one. What about if you have persistent rhinorrhea with onset in first 3 months of life? Ganyan ka bata, ganyan ka baby, and you call it snuffles. What do you think is this one? Yes, that could be one of the manifestations of congenital syphilis. What about if you have history of prolonged use of topical or oral decongestant? Yes, it's called rhinitis medicamentosa. What about paroxysms of cough? Let me rephrase this. This is also described as series of cough. Okay? And 5 to 10 cough in one episode. Toward the end, there is a musical sound that you will hear. And because of the gravity of the coughing, sometimes this leaves the baby breathless. And sometimes they develop rupture of the vessels in the subconjunctival area. Hardly that there is fever. Usually you have normal breath sounds. But what's very peculiar here is the pattern of the paroxysms or the series of cough ending with a musical sound. I'm talking about a whoop, which makes your diagnosis pertussis or whooping cough. Okay? Paroxysms yun, paubo-ubo. Kaya lagi kong tinatanong din dun sa nanay, no, ang ubo ba niya sunod-sunod? 5, more than 5 sa isang episode lang? Tapos the patient is well in between. That is a very common presentation of pertussis, especially in young children. Let me now go to the second respiratory problem, the type of respiratory problem. Let's now go to lower airway obstruction. And you can see here in blue that these are the prototypes of conditions presenting with lower airway obstruction. For this type, what you hear is wheezing. Okay, linawin natin ha. Upper airway obstruction, stridor. Mainly inspiratory in timing. Lower airway obstruction, wheezing. It may be biphasic, but most commonly expiratory in timing. Okay? So, of course, ayan na naman yung increased respiratory effort, meron kang prolonged expiratory phase, of course, there's coughing and decreased air movement on auscultation. So, to differentiate the two conditions presenting as lower airway obstruction, first, ang bronchiolitis, infectious yan. Okay? Affecting the first 2 years of life. So, again, there is cough, colds, fever. Remember, cough, colds, fever, lagi yan. But, in the ensuing days, magiging very notable yung wheezing upon auscultation. Again, bronchiolitis, just like croup, is clinically diagnosed. This is due to respiratory syncytial virus. The typical course of illness peaks at about 3 to 4 days wherein dun sila nahihirapan, dun talaga yung onset ng wheezing, dinig na dinig nyo with the stethoscope. Chest x-ray is not routine, but yes, yeah, you may do it because maybe if you want to rule out superimposed or a concomitant bacterial infection, no? But this particular condition, bronchiolitis, is one example of the saying na not all who wheeze has asthma. Kasi ito, very particular, very prominent sa kanya yung wheezing. So, titingnan nyo dyan ang edad. Basta first 2 years of life, 6 months, 8 months, okay? First time wheezing, lalo na fever, cough, colds, wheezing, that's bronchiolitis. Especially high risk factors for this age group to have bronchiolitis, those with history of prematurity when they were born, and those with a chronic lung disease, let's say preterm, and then has been taken care of in the NICU, neonatal intensive care unit, and the patient eventually developed chronic lung disease. Okay, so this will be the ones who might develop bronchiolitis as they are growing older, and the ones who have congenital heart problems. And the fourth one is patients who are exposed to cigarette smoke. Okay, so environmental factors. Okay, prematurity, exposure to smoke, history of chronic lung disease, and history of congenital heart problems. These are the top 4 risk factors for associated with development of bronchiolitis. Okay? To differentiate it from asthma, which is also lower airway obstruction, with asthma, what you are dealing with is chronically inflamed airways. Number 2 problem, increased production of mucus. So kung ito ang top 2 problems ng asthma, you will be led next to the top 2 management. For chronically inflamed airways, definitely we give steroids. And because there is also bronchoconstriction, bronchospasm, we give bronchodilators. Okay? Hence, those 2 medications are part and parcel of the management. Okay? So, notable also for asthma is the nocturnal timing of cough. Lagi ko yan tanong. I never fail to ask parents who bring their children and they say, Doc, ang tagal na ng ubo. Okay, kailan? Nagigising ba siya sa sleep? Nadi-disturb ang sleep? Ay, opo, pag madaling araw. Okay, so alam na. Okay, so wheezing is prominent. Of course, for asthma, the triggers, most common pa rin, viral ortiz, cough, colds, fever. But then again, followed by environmental triggers such as palit ng panahon, okay? Tapos pollens or other dust mites, okay, in the household. These are also triggers. Physical activity, there's what we call EIA, exercise-induced asthma. So these are some of the triggers, okay, for asthma. So in terms of chest x-ray findings for bronchiolitis, so just like obstruction conditions, you expect hyperinflation or hyperaeration of the lungs. And then when we admit them, it means that they are very tachypnic, with lots of manifestations of increased work of breathing. Hence, they would need support, oxygenation support, especially if the initial O2 sat at room air is less than 94%. And then we basically manage them by giving supportive treatment such as taking care of the oxygenation as well as the hydration and nutrition. And the hydration status, we usually compute that with maintenance plus 12%. If you recall in Nelson textbook of pediatrics, we are to give additional 12% to the maintenance fluid in order to take care of the insensible losses because of tachypnea. Okay? There is no role for bronchodilators as stated in systematic reviews of bronchiolitis, but you will recall that maybe some of the consultants that you've worked with have started salbutamol also because there is wheezing, right? So they might have started the patient on salbutamol nebulization also as part of their supportive management. But if you go by evidence, supposedly there is no role for bronchodilators. But yeah, you can also try that. Anyway, these are guidelines, and guidelines are meant to be reviewed periodically and on a regular basis. For asthma, what we are following, of course, is GINA guidelines. This is Global Initiative for Asthma, which has been adopted by the Philippine Academy of Pediatric Pulmonology back in 2021. So it's still the same. We classify it based on severity, and then we look at whether the category is intermittent or persistent. Under persistent, if it is mild, moderate, or severe. And then we classify the level of control. Yung asthma ba ng patient ay uncontrolled, partly controlled, or controlled? So this is lifted from the aforementioned GINA guidelines and the Philippine Academy of Pediapulmonology 2021. For those specifically below 6 years old, we look at the duration and the pattern of respiratory symptoms. So pag na-elicit natin, let's say merong theoretical question, no, o kaya case-based question, pag name-mention talaga yung coughing, especially nighttime, tas may wheezing, heavy breathing for less than 10 days during ORT, and if you review, pag na-mention doon, 2 to 3 episodes per year, ang classification nila, maybe few have asthma, okay? Whereas, if there is coughing, wheezing, heavy breathing for more than 10 days, no, during an ORT bout, a bout of ORT, and then more than 3 episodes per year, or there are severe episodes and or night worsening, then experts said some of these patients might have asthma. Ang difference nito, no, kasi the same na more than 10 days na yung duration of the coughing, wheezing, and heavy breathing, and then more than 3 episodes then, is, okay, the next slide will show it here. If between the episodes, the child has cough, wheeze, or heavy breathing during play or when laughing, and if they are known to have allergic sensitization, like they also have atopic dermatitis, food allergy, you know that there is what we call a atopic march, wherein the earliest possible manifestation of atopy and even allergy is of course manifested sa skin, atopic dermatitis here during infancy. The location of the rashes there are classically here on the cheeks and on the extensor surfaces. It's very rough. They're very fine, red, scaly rashes here. Okay, rough to touch. Okay. If we're talking about atopic dermatitis in older children, more than 1 year old, then the usual location of these rashes, aside from the cheeks, are here on the flexural surfaces. Okay? So from skin, magmamanifest sila ng food allergy 1 year old, 2 years old kasi 'di ba nag-complementary feeding ng 6 months old. So chances are whatever it is that they are being fed, especially no kapag 1 year old and older, dun magmamanifest yung ibang food allergy as early as 1 year old onwards. And then if they have allergic rhinitis also, which is basically manifesting 1 year old, 2 years old and above, and then asthma of course. So this spectrum, if they fall under that, then it increases the likelihood that there could also be really asthma in this particular patient. So this becomes more likely to be asthma. But you can see here in the other categories that if there is just, less than 10 days of all of the symptoms, and then there are no symptoms in between, then the experts call it as having less likely to have asthma. And then this one is asthma suspect. Balikan ko lang yung isang slide ha. This one is more than 10 days of coughing, wheezing, heavy breathing, more than 3 episodes per year with night worsening. Tapos if you go down this central part of the column, between the episodes, they have occasional cough, wheeze, or heavy breathing. Then this is what they call asthma suspect. So I use this table heavily in patients whom I consider and whom I'm trying to establish if indeed there is asthma or not. Okay, again, this is the 2021 guidelines. So what about, again, the diagnosis? How to diagnose these kids less than 6 years old based on patterns of respiratory symptoms? Okay. Again, for the presence of wheeze, shortness of breath, chest tightness, and cough, if there is usually more than one type of symptom, occurs variably over time and vary in intensity and often worse at night or on waking, triggered by exercise, laughter, allergens, cold air, that's cold air, and often appears or worsens with viral infections. Yes, no? Ito yung mga symptomatology natin or the criteria rather for diagnosis. And then if we do your pulmonary function tests, you look at the forced expiratory volume of all of this. When at the time when the forced expiratory volume is reduced, we confirm then, especially no, if it is compared to the functional vital capacity, if it is altogether reduced, then yes, you might really be dealing with asthma in the less than 6-year-old age group. Now, the diagnosis of asthma in the next age group, I'm talking about 6 to 18 years old, also based on patterns of the respiratory symptoms. So pareho lang, no? Andun pa rin yung wheezing, nighttime coughing, heavy breathing, okay? And then if there is documented excessive variability in lung function tests, the good thing with this age group, 6 to 18 years old, especially the 6 years old and above, they are now older, wherein they could now follow the specific instructions if they're doing the pulmonary function test. Okay, so if you are able to do that, if the patient is able to do that, the greater the variations, the more confident that we diagnose that they have asthma. Okay, we look also into the bronchodilator reversibility test. Okay, so if there is increase in the forced expiratory volume from the initial puff, okay, as they blow into the machine, if there's increase of that more than 12% predicted, then yes, kasi kung nag-improve siya, okay, na reverse with the bronchodilator, yes, you are looking at, again, asthma in these patients. And here are the other ways of diagnosing this. But basically, this is just the use of your pulmonary function test in this particular age group. Okay, what about exacerbation? What about if they have an acute attack of asthma? Okay, still using the 2021 guidelines, okay, we divide the age group into less than 6 years old and again the 6 to 18 years old. But you can see here that the categories or the classification of the acute attack is mild, moderate, or severe or life-threatening. So we look at the activity or the sensorium. So in other words, if you encounter a case-based question, if the patient is being described as less than 6 years old and is described also as still active, alert, playing, okay? And then there is no increase in RR, but you hear wheezing, yes, they are having asthma exacerbation or asthma attack, but it may just be mild or moderate based on the assessment of the RR, the cardiac rate, the pulse ox, okay? But yes, they have wheezing. Okay, you get it? Nagwi-wheeze sila, pero mild lang. Maraming ganyan, di ba? Sasabihin dun sa ER, Dok, inaatake ng asthma. Okay, pero makikita nyo, nag-gadget. Di ba ganon? Oh, you have asthma daw, you have difficulty of breathing, yes, pero nagaganon, hindi mo ma-distract from the use of their gadgets, 'di ba? Maraming ganyan. Of course, it's a different story if you're dealing with a less than 6-year-old kid, but this time the presentation is severe when they are already breathless, unable to talk. Of course, they are tachypnic, they are tachycardic, and then they have low initial oxygen saturation. Of course, you're dealing there with a severe category of attack or exacerbation. For 6 to 18 years old age group, it is still categorized as mild, moderate, severe, and even life-threatening, but you can see the progression of the deterioration of the sensorium. From mild to moderate, able to talk pa yan. Pero pag moderate, in phrases na lang. Pag severe, wala, hindi nyo na makakausap yan. Yung life-threatening, drowsy, lethargic, confused na yan. Yung life-threatening asthma attack sa ganitong edad. And again, we count the RR, we count the cardiac rate, what is the pulse ox. Of course, if that's less than 90%, then yeah, clearly that's a severe exacerbation or attack. Okay? So, let's again be guided by the WHO resting respiratory rate for us to determine whether the RR that we counted is normal for age. 1 month to 12 months old is less than 50 per minute. That's still normal. So, higher than 50 is tachypnea for this age group. Yung hindi lang nakalagay dito yung neonate kasi hindi naman nag-asthma ang neonate, di ba? But sa pneumonia, makikita nyo naman, of course, more than 60. Kasi remember, the normal range of RR in a neonate, in a newborn, is 40 to 60 breaths per minute. Okay? So, yun. Pag 1 month to 12 months old, less than 50, that's normal. 1 to 5 years old, less than 40. 6 to 10 years old, that's less than 30 per minute, and 11 to 18 years old is less than 20 per minute. Okay? So, madali namang tandaan kasi pababa lang siya ng pababa. 50, 40, 30, and 20. So, kapag more than yung mga ganyang values, definitely that's defined as tachypnea. You consider hospital admission when the patient has any of the following clinical criteria. Yung pagkinwento sa'yo o kaya nandun sa case-based question, the patient was already started on salbutamol inhaler or the patient was already nebulized at home 6 times in the past 24 hours and still presenting with dyspnea, with tight air entry or occasional wheezing, then yes, you might need to admit the patient in a hospital setting. If the peak expiratory flow rate using the tube is 50 to 75% of personal best, if you have history of severe exacerbations before, that warranted ICU admission, then that's one of the red flags for us to really look into the overall condition of the patient and our decision to admit them. Hospital admission or previous exacerbation for the past 12 months, and of course, other considerations like maybe tinitingnan din natin, saan ba sila nakatira? Baka remote location, poor access or far or hindi maganda yung matagal, I mean, ang tanong ko, gaano katagal from your house to the nearest hospital na pwede siyang manebulize? Pag sinabi sa akin, Doc, ang layo namin, 30 minutes, malayo sa akin yun. 15 minutes, pwede pa. Pero, alam mo yon, it's a judgment call. Kung hindi rin complete yung hospital na yon for managing, critical patients and of course, status epileptico, status asthmaticus, epilepticus tuloy, status asthmaticus, yes, then you might want to decide to admit the patient for that condition. Okay? I know this is a small slide for you to look into, but I'll just walk you through what should be done with regards to management of acute attacks of asthma in less than 6 years old if you are dealing with this patient in the OPD. So, ganun pa rin, you remember this part, balikan ko lang ng mabilis. Ito ulit yung this one. How to categorize the type of asthma attack. Okay, mild, moderate, or severe. Okay? Using the parameters, assessing the sensorium, counting the RR, cardiac rate, and the pulse ox. Okay? So, ito yung tinitingnan natin. So, basta mild to moderate, nebulize pa rin tayo. But you know what? Since the advent of COVID, di ba bawal yung mga aerosol generating procedures in the ER. What we do there is we have isolation rooms, we have tents, but of course we don't use tents nowadays kasi nga supposedly endemic na lang, no? But still, no, for for aerosol generating procedures, okay, like that, ideally in the hospital where you work, ideally naka-segregate siya or naka-separate siya. Kasi we still need to identify whether we're dealing with COVID or not. Anyway, if the patient is in an outpatient setting and you are able to nebulize the patient there, the other option is to have the meter dose inhaler, okay? And then you attach that to the canister there, di ba? Para yung delivery ng flow, diretso doon. Tapos, diretso dito sa target organ, which is, of course, your airways, the nose, and then going down to the lungs. Okay, so you might want to use the meter dose inhaler with a spacer. And the action of salbutamol, inhaled salbutamol through the spacer or the nebulizer is the same because you are targeting the lungs, okay? So we give salbutamol at least 3 doses if you are nebulizing, 1 nebule, di ba? 3 doses 20 minutes apart. If you're using the inhaler with a spacer, we use salbutamol inhaler. We give at least 2 puffs, okay, or 2 to 4 puffs. Made-deliver siya through the spacer, naka-mask, mai-inhale ng pasyente. We do that again 3 times. Okay? Every 20 minutes, we reassess in between. If there is good response to that, of course, we send them home, basically using the salbutamol inhaler or the nebulization. And then don't forget to, while managing them at the outpatient department, we also address the chronically inflamed airways by starting the patient on steroids. So we give, if they are just mild, if that is just mild exacerbation, meron ka lang steroid na prednisone, okay, pwedeng tablet, or tablet sa older children, or of course, your syrup of prednisone, 1 to 2 milligrams per kilo per day. Short course, 5 days. No need to taper the doses because you're just giving it for 5 days. Okay? Again, this is given alongside with the salbutamol nebulization or the use of inhaler. Kailangan ma-start talaga ang steroids na kasi chronically inflamed airways yon. Halimbawa, yung less than 6 years old, moderate to severe, imbes na oral, then the choice of giving steroid is IV. Hence, you may use the IV equivalent of steroid, which is methylprednisolone, 1 milligram per kilo per dose, or hydrocortisone. If the hospital doesn't have methylpred IV, you may give hydrocortisone IV at 2 milligram per kilo per dose. And then we assess for response to treatment, the RR going back to normal, the sensorium being much improved, being able to tolerate medications, and then close to a hospital, definitely we can send them home, especially if it is just mild to moderate. Ibang kwento pag severe or life-threatening. From the OPD, dinadala yan sa emergency room. Okay? It's the same for the 6 to 18-year-old age group having asthma attack in the outpatient setting. Again, classifying whether it is mild to moderate, hence needing again salbutamol nebulization or the use of inhaler, and then starting them on oral prednisone or IV steroids such as methylprednisolone. Again, if the presentation is severe or life-threatening, we accompany the patient to the ER because your plain salbutamol will not work with severe or life-threatening exacerbation, which means in the algorithm, instead of plain salb, we shift the patient to giving, we now give in the what's mentioned here, salbutamol with ipratropium. Okay, so if you know Combivent, Duavent, those are the common brands for salbutamol and ipratropium bromide, which is the step-up management for managing or for treating severe exacerbations of asthma. Pag hindi nasusustain ang effect ng plain salbutamol, we shift the patient to salbutamol with ipratropium, nebulized ito. Ganun din, 20 minutes, 3 doses apart, reassess in between, and definitely pag severe yan for admission. Okay, so that's how we do it. Okay. In the hospital setting, basically it's the same. It entails the practitioner, okay, the doctor, to identify what kind of exacerbation or severity the patient has. Is it moderate, severe, or life-threatening? So again, if it is already severe and life-threatening, so it has to be salbutamol with ipratropium. It is mentioned here in the small boxes, either through inhaler or nebulization. Repeat every 20 minutes for 1 to 2 hours. And of course, again, IV steroid. Okay, so pareho lang. So, some principles again to remember. The target O2 saturation for 6 to 11 years old is 94 to 98%. In adolescents, it's 93 to 95%. So if it's less than 92%, it's a predictor really for hospitalization. And of course, if it's less than 90%, we are more than aggressive in instituting the needed therapy ASAP. Patients not on controller meds should be Ibig sabihin ng controller, yung maintenance. Okay? Yung maintenance nila na salbutamol with the steroid. If they are not on maintenance, they should be started on regular inhaled corticosteroids containing treatment. That is if they have acute attacks. Okay? And sabi nga sa latest guidelines, mas cost-effective pa nga ang through inhaler. Ang problema dyan yung availability ng spacer because the cost of the spacer is quite prohibitive, especially if you're taking care of, families from the marginalized bracket, no? Medyo prohibitive siya talaga. But of course, you can always use that, no? Whether in a government or in a private setting. And I already mentioned for moderate to severe attacks, you need to give the ipratropium combination with salbutamol. Ito pa ang isang reminder ko. Inhaler plus spacer with face mask. No? Face mask, 0 to 3 years old. Pero yung mouthpiece, kunyari nagpapanebulize kayo, yung sa bibig na, yan pang 4 to 5 years old. And of course, for older children. Okay? Pero yung face mask, ideally yan yung ginagamit natin na oxygen delivery system or salbutamol delivery system pag 0 to 3 years old when we're dealing with nebulization. Some important points, systemic steroids that I mentioned earlier as part of the management, they're equally effective whether oral and IV form, meaning pareho lang sila ng bioavailability. It would take about 4 hours for the steroids to, the action to have its peak. Okay, so whether oral or IV, nagkakatalo na lang talaga whether the patient is alert and awake, not vomiting oral. But if severe attack, pangit ang work of breathing, definitely that's we give steroids through the IV form. Okay, and these are the doses. If prednisone and prednisolone, of course, are your oral forms, and these are the doses. I mentioned it earlier, 1 to 2 milligrams per kilo per day, and this is for the other age groups. We give at as much as 40 milligrams per day for 6 years old and above. And I mentioned also the IV form is methylprednisolone at 1 milligram per kilo, okay, every 6 hours. Some principles again in the management, part of the latest guidelines. Let's say that the patient has just acute attack that is mild, and then for discharge, then it is recommended that we start the patient on inhaled corticosteroids to reduce further attacks and hospitalizations and to reduce mortality. The combination of inhaled corticosteroid with a long-acting beta agonist. Remember, ang salbutamol, SS, short-acting yun, SABA. Ang recommendation ngayon, magpa-start daw after the acute attack ng formoterol is the long-acting beta agonist with steroid. Okay? So formoterol with steroid yon. It improves symptom control and addresses inflammation at its onset. Although there is still insufficient evidence on safety and efficacy of this combination in less than 14 years old. Ipratropium bromide, again, for moderate to severe exacerbations across all ages. What about magnesium sulfate? This is not routinely given for acute exacerbation. Okay? This is an add-on treatment in the first hour if severe exacerbation. A single dose is given 40 to 50 milligram per kilo by slow IV infusion, reaching 1 hour for it to finish. Supposedly, it will reduce hospitalization, but we don't use it in less than 5 years old because of paucity of data. Wala pang masyadong research. How about Montelukast, leukotriene receptor antagonist? There is still limited evidence to support its use in the ER setting. In other words, hindi siya ginagamit kapag may acute attack. Add-on siya sa maintenance treatment of those with asthma, but not for acute attack. Okay. So again, this is just a summary of the treatment that we give for 6 to 11 years old with asthma, wheezing, or even suspected asthma. Okay, so makikita nyo talaga, ang sinasabi lang dito guys ay yung paggamit ng low dose combination of steroids. Okay, for 6 to 11 years old with asthma. So we are also using this, we utilize this screening tool to assess the control. Again, well-controlled ba yung asthma, partially controlled, or uncontrolled? So it depends on how many yeses we tick. So the look back is 4 weeks ago. So when we ask the parent, has the patient had daytime symptoms more than twice a week? SABA reliever was used, lagi bang gumagamit ng puff, ng salbutamol more than 2 times a week? How about nighttime waking up because of asthma attack? And how about limitation of activities because there's asthma attack? Again, depending on the numbers of yes that you tick, then that is how you determine whether the patient's asthma is well controlled, partially controlled, or uncontrolled. But you look at the potentially modifiable risk factors for exacerbations. Minsan kasi, incorrect ang technique of using the inhaler o kaya hindi nga siya nakastart ng steroid or there is poor compliance to medications. And of course, you look at the comorbidities. Is the patient with asthma obese? Is there chronic rhinosinusitis? Are you dealing with also GERD, confirmed food allergies, and other comorbidities? The environment, the setting, okay? Prior intubation before, of course, medyo pangit ang outcome kasi pag may prior intubation na, no? So, again, this is just to reiterate the latest guidelines that supposedly every adult and adolescent with asthma should receive now a combination of steroid to reduce the risk of serious exacerbation. So, ang reliever inhaler naman nila, pag may acute attack, may low dose talaga na long-acting beta-2 agonist with steroid. Okay, ICS is inhaled corticosteroid. Okay, I already mentioned this earlier, the one with what if there is asthma exacerbation. So, as I said na life-threatening na, no, or severe. Ito nga yung your bronchodilator with ipratropium bromide. So, ito yung pinalaking version lang nung maliliit na tables kanina. Okay, so let us look at this table. What if the patient has wheezing and then there's history of viral infection among the family members? The patient is 2 years old. The patient presents with fever, cough, colds, first time wheezing, first 2 years of life. If you answered, yes, that's bronchiolitis. Di ba yung sabi ko, infectious, family members are ill, first 2 years of life. What about wheezing and then there's history of atopy in the family, there's recurrent wheezing, especially after mild viral infection or noted after exercise. Strong family history of atopy. If you answered asthma, you are correct. What if there's noisy breathing when crying, eating, or during respiratory tract infections, may poor response to asthma medications, and symptoms are there since birth? Yung symptoms na present since birth, clue na yon, red flag na yon for a possible structural abnormality that presents with wheezing and that tends to persist even beyond 1 year old. Yes, that could be tracheomalacia or laryngomalacia. So, pagkapanganak pa lang, meron talagang noisy breathing. Okay? Tapos, pwedeng may wheezing. But then again, bronchoscopy is done by the pediapulmonologist. And if they see the structural problem there, the weakening, okay, or the underdeveloped aryepiglottic folds leading to this structural problem of laryngotracheomalacia or laryngomalacia, the basic management is, if this is picked up or identified during infancy, we tell the parents that specifically we have to wait it out. This is what we call expectant observation, because we expect that by 12 months old, all the structures have matured, have developed more, so that there will be the disappearance of all of this noisy breathing. Mawawala na yung noisy breathing na yon. So, in other words, if the patient's condition will persist beyond 1 year old, then we refer back to Pediapulmo for further evaluation. But basically, if this is laryngomalacia or laryngotracheomalacia, then yes, we just have to observe the patient and reassure the parents. And we tell them what to watch out for in terms of symptomatology. What about a patient with wheezing and then there could be absent breath sounds on the affected lung, in this case, right lung. Patient is 3 years old. Bakit sinasabi dyan yung 3 years old? Kasi yung sudden onset of difficulty of breathing in a patient who is, the age is between the first 3 years of life, sudden onset, previously well, foreign body, airway obstruction, di ba? Pwede siya mag-wheeze kasi depende kung napunta siya sa lower airway, pwede siyang may wheezing. The next type of respiratory problem is signs of lung tissue damage. So in this part, the prototype, of course, the common example is pneumonia, or you may be dealing with pulmonary edema, trauma, or even infiltrative disease, and even toxins. So this is what we call restrictive lung disease or lung tissue damage. Imagine pneumonia, because this is the prototype example of this mechanism of problem. No? Pneumonia literally means there's inflammation of the lung parenchyma. So when there is inflammation of the lung parenchyma, imagine that there is restriction of the lung as it inhales, as it expands, because of the infection there. So clearly, this will lead to decreased lung compliance, poor elastic recoil. So, when these events happen, a child or a young infant with pneumonia, as he inhales, diba? Meron ka ng takip niya, increased effort. Okay? As he inhales, the passage of air going through the alveoli, which are the terminal portions of the respiratory tract, because of this inflammation, the alveolar sacs are already filled with fluid. Now, the interaction of the air, as the patient inhales, air interacting with the air fluid levels in the air sacs will now lead to the production of your crackles or rales. They're synonymous. Crackles is English, British. Rales is French. So if you feel French for the day, I'm hearing rales. Okay? Pero pareho lang yon. No? So in other words, pag inhale ng bata, Interaction ng air tapos dun sa fluid na nasa loob ng alveoli, ayun na yung crackling sound. So hence, yung crackles mo ay associated with restrictive lung disease, mainly heard during inspiration, could be heard also expiration, but basically this is mainly heard during inspiration, non-musical sound. Unlike yung wheezes nyo tsaka stridor, musical sound siya. Crackles are non-musical, discontinuous, heard during inspiration, associated with restrictive lung disease. Okay? So, those are the explanations for that particular problem. Now, we concentrate on pneumonia. Etiologies in young infants. Especially, I'd like to zero in first on the newborn period again, the 0 to 28 days. Just like sepsis, neonatal sepsis, and in neonatal pneumonia, ano pa? Neonatal meningitis, common dyan talaga group B strep. Number 1, group B strep followed by E. coli. In the States, there is Listeria pneumoniae, no? Pero pinaka-common pa rin talaga ang group B strep and E. coli. Kaya nga siya, di ba, at least 48 hours prior to giving birth, may screening, di ba, for group B strep dun sa mami kasi baka ma-transfer niya dun sa baby. Okay? And then, there's a particular age group that I'd like to emphasize also. I'm talking about 3 weeks to 3 months old na babies. Okay? The pneumonia there usually is what we call atypical. Okay? Atypical respiratory infection. And highlighted there is chlamydia pneumoniae, wherein the characteristic features of these infants 3 weeks to 3 months old is that, yes, there is cough, but hardly that they have fever. Most of the time, if not, worse is low-grade fever. But most of the time, the parents would say, hindi naman po siya naglalagnat. Ubo lang siya ng ubo. Gano'n na ho katagal? 7 days po. Yung iba sasabihin, Dok, magto 2 weeks na. Ganun talaga yung course ng atypical pneumonia sa 3 weeks to 3 months old. And they are not in distress. Nagfi-feed ba? Opo. Maganda ang feeding, walang distress. May have some, occasional rhonchi, but rhonchi is just, transmitted sounds. Nandun siya sa medium-sized airways. Rhonchi does not reach the alveoli. Ang naririnig nyo pag crackles, tandaan nyo, nasa alveolar sacs na yan. So, atypical siya talaga. They hardly go into really severe type of respiratory distress. Okay? So, what you give for this patient is, of course, a macrolide to address the chlamydia. One more thing. Sometimes the parents, tinatanong ko yung mami, may ubo ka? Okay. Or history of eye discharge in the baby. All the more it increases the likelihood na chlamydia yon sa 3 weeks to 3 months old. May ganito pang kwento. Sasabihin nila, nag-amoxicillin na siya, nag-cefixime siya, nag-cefuroxime siya, nag-co-amoxiclav siya, no improvement. All the more na kailangan mong i-shift sa macrolide. Kasi 3 weeks to 3 months old yan, chlamydia yan. It's not strep, it's chlamydia for this age group. Okay? Now, 4 months to 4 years old or some textbooks 5 years old. Number 1 cause pa rin ng pneumonia worldwide, virus. Virus pa rin. But among the bacterial etiologies of community-acquired pneumonia in 4 months to 5 years old, number 1 is still strep, followed by Hib, and last is Mycoplasma pneumoniae. Now, for older children going into adolescence, 5, 6 years old and above, the number 1 cause now is atypical Mycoplasma, followed by strep. Pag inisip nyo ngayon, very important yung slide na to, why do I want you to remember this? Because your initial empiric drug of choice for pneumonia depends on the age group. Pag nakita nyong may pneumonia ang newborn, definitely for admission. Hindi pinapauwi yan. We give a medication to go against group B strep. Usually, we start with ampicillin IV. As I said earlier, 3 weeks to 3 months old, chlamydia, Outpatient yan, pinapauwi ko lang. Kasi nga sabi ko, atypical, they are not in distress. Inuubo lang, disturbing cough. Normal O2 SAT, normal RR. Hardly there is fever. Normal breath sounds. Binibigyan ko lang yan ng azithromycin or clarithromycin or erythro. Remember your macrolides. 4 months to 4 years old, as I said, sa bacterial cause, strep pneumo is still the number one. You will see later in the guidelines, it is still amoxicillin-based. Amox pa rin. But definitely, may ibang drug of choice kung admissible yung 4 months to 5 years old na may pneumonia. But for outpatient, it is still amoxicillin. For mycoplasma, atypical pneumonia, atypical organism, again, just like chlamydia, we give the patient macrolide. Okay? The second most common one would be strep pneumo then. Okay? So this slide is very important as to our decision making with regards to the initial drug of choice. Okay? So here I am quoting 2021 PCAP guidelines, that is Pediatric Community Acquired Pneumonia guidelines by, again, the Philippine Academy of Pediatric Pulmonology, referring to the accurate diagnosis of pneumonia in 3 months to 18 years old. So, ito yung pagkaka-define ng pneumonia sa ganitong age group. A patient who has cough, fever, plus any of the following. Cough and fever plus grunting. Grunting, you don't need a stethoscope. Actually, most of the time you will hear that. Even without a stethoscope, it's very audible, and classically, this is heard during expiration because the patient is trying to, as he is going through the inhalation and exhalation phase of respiration. Pagdating ng exhalation phase, so nag-grunt. Usually during the expiratory phase, low pitch sound, low to medium pitch sound, putol-putol, and that is associated with the patient's attempt to breathe through a partially closed glottis. Okay, so grunting, pag may ganyan, cough fever with grunting, cough fever with retractions, cough fever with O2 SAT of less than 95%, with alar flaring, and then tachypnea again. Okay, so sabi ko nga sa inyo, sa PEDS, depende sa age group. So ito yon ulit yung mga cut-off ages natin para ma-identify natin kung tachypnic sila or hindi. Okay? And then, the new version, okay, for risk classification is, for pneumonia, is low risk, also known as non-severe or high risk. Before kasi, yung 2016 guidelines ng the same Association ng Philippines, before, ang tawag nila PCAP A, PCAP B, non-severe, PCAP C, severe, PCAP D, very severe. Fast forward 2021 guidelines, they now just simplify the classification by having just 2 categories, low risk, high risk, non-severe, severe. Pinagsama na yung PCAP C and PCAP D under high risk. But the parameters are still the same. We look at the respiratory signs. Syempre, kung may cyanosis, head bobbing, retractions, apnea, grunting, high risk. Apnea is temporary cessation of breathing for more than 20 seconds with cyanosis and or bradycardia. Very precise definition. Temporary cessation of breathing yan. What about the CNS signs? Tinitingnan natin. Siyempre, ayan na naman yung sensorium. Kung active, irritable, alert naman, low risk. Pero yung lethargic, stuporous, of course, comatose, ayaw natin yun. Severe na yun. Convulsions, walang convulsion. Ito, convulsion, basically, baka kasi hypoxic. Diba? Kasi kung baksak ang O2 SAT. So, pag may hypoxia, pag may convulsion, of course, that's already high risk or severe. The additional parameters are, we look into the perfusion. So, dito, sa nail beds, So, if it's more than 3 seconds, the capillary refill time, that's already high risk. Pag pallor, sobrang putla, that's high risk. And the other clinical parameters like looking into the weight. Kumusta ba? Malnourished? Hindi. Low risk. Moderate to severely undernourished? Yes, that's part of being high risk pneumonia. Refusal or inability to drink, feed, or take oral meds. Okay? Syempre, the more serious, the more presence of the problematic parameters, syempre mas high risk yun. Age less than 6 months, the age itself, being, a very young infant is already a high risk criterion for the possible pneumonia-related mortality cases. And of course, chest x-ray as part of ancillary parameters, yung meron kang consolidation, yung puting-puti, yung lung mo, okay? Of course, that's high risk. Lalo na kung may abscess, kasi kung abscess, definitely baka staphylococcus yan, acute onset, high-grade fever, okay? And then sustained O2 saturation at room air, equal or more than 94%, that's low risk, but equal or less than 93%, that's high risk for pneumonia-related mortality. Okay, I'd like to highlight the other diagnostic aids that they use to confirm the presence of severe pneumonia in a hospital setting. Chest x-ray is strongly recommended as an initial diagnostic aid for patients classified as severe, and this is with high-grade evidence. Point-of-care chest ultrasound. Yes, in our hospital where I work, we do chest ultrasound by the bedside to identify B lines. That's the presence of your pneumonia. If you have the benefit of using bedside point-of-care ultrasound, yes, and they can identify really severe cases. Procalcitonin, one of the inflammatory markers, can be also used to identify and to diagnose. Sputum, gram stain, and culture, however, are not considered to be done routinely in severe cases. No, that's not part of our workup. CBC, blood gas, serum electrolytes are considered as necessary based on clinician's evaluation, and this is by expert opinion. But yes, you know that if you recall again your rotations, that's part of our initial set of diagnostics, di ba? May blood, may CBC tayo, may chest x-ray tayo, and of course ABGs. We go to the empiric treatment. As I said, for the non-severe PCAP, which means they can tolerate oral medications regardless of immunization status against strep and Hib, ang ibibigay nyo amok. So kung binigyan kayo ng case sa exam, first thing to do is to identify, is this pneumonia? So babalik tayo, fever, cough with, pwedeng granting, baksakang O2 sat, di ba? May mga signs or the signs of respiratory distress. Tapos the next is to identify, am I dealing with non-severe o severe? So pag non-severe, let's say 4 months to 5 years old, strep pneumo, amoxicillin. Okay? So, it's either you give it 40 to 50 milligram per kilo per day, Q8 for 7 days, or at a higher dose, 80 to 90 pero Q12. Okay? Or, this is hindi sabay, or amoxicillin clavulanate. Also at 80 to 90 milligrams per kilo per day, Q12. The advantage, of course, of giving it just twice a day, every 12 hours, is for better compliance, no? Mas madaling ipainom like 1 in the morning, 1 in the evening. Or cefuroxime in settings with documented high-level penicillin-resistant pneumococci or beta-lactamase-producing Hib. Okay? Of course, this is based on the local resistance data or even the hospital antibiogram. But if you're dealing with severe PCAP, ito yung high risk dun sa table. Regardless of strep pneumo immunization status, any of the following is considered. So, you may give PenG, 200,000 units per kilo per day IV, if with complete Hib, or ampicillin, 200 milligrams per kilo per day if with no or incomplete or unknown Hib vaccination. So, tinatanong din natin yun, no? So, again, pag sinabi, ano ba yung complete Hib vaccination again? Depende yan sa edad. Kung ang edad nila 10 months old, ang assessment nyo severe or high risk pneumonia for admission. Kapag complete ang HIB, ibig sabihin kung 10 months siya, nakatatlo siyang doses, yung 6, 10, 14 weeks, PENG ang ibigay. Yung example ko na 10 months old, for some reason, isang beses lang siya nagpentahib, yung 5-in-1 vaccine na binibigay sa center, nakasama na dun yung strep tsaka hib. Okay? So pag sinabing, ay isa lang ho for whatever reason, isa pa lang ang nabibigay sa kanya, 10 months old siya, theoretically, dapat tatlo yon, 6, 10, 14 weeks. Isa pa lang, ampicillin ang ibibigay. Okay? So I tried to paint a picture kung ano yung scenario na kailangan ma-determine ang vaccination status that will lead you to your decision whether it's PENG or ampicillin that you would give for severe pneumonia. Moving on, nasa severe pneumonia pa rin tayo. Kasi nga, di ba, any, so pwede rin daw Cefu. This is Cefu IV, that's every 8 hours, or ceftriaxone or ampicillin sulbactam in settings with documented high-level penicillin-resistant pneumococci or again beta-lactamase-producing HIB. You may add clindamycin when staphylococcal pneumonia is highly suspected based on clinical and chest x-ray features. Again, pag staph pneumonia, very acute. I'm talking about 48 hours onset of fever, cough, tachypnea, and or grunting with alar flaring, increased work of breathing, the works. Okay? And quick deterioration of sensorium. And chest x-ray findings of abscess or multiloculated abscesses in the lung fields. Then, clinically, that may be staph aureus. So we add clindamycin. And in cases of severe and life-threatening conditions, of course, vancomycin, especially if we're dealing with MRSA, methicillin-resistant staph aureus. Now, for patients with known hypersensitivity to penicillin, like non-type 1 hypersensitivity, the recommendation is cefuroxime or ceftriaxone. For type 1 hypersensitivity, any of the following. So you may use now your macrolides for type 1 hypersensitivity to penicillin, macrolide like azith or clarithromycin. When an atypical pathogen is suspected, like yung sinabi ko na 3 weeks to 3 months old, tapos older children and adolescents na may atypical pneumonia or walking pneumonia, kasi nga pag atypical, hindi naman sila talaga in distress. So if this is suspected, azithromycin, as I said, as a macrolide, or clarithromycin. Now, if you are able to prove that the pneumonia has a viral etiology, and most of the time, this is of course through nasopharyngeal and or oropharyngeal swab. Sa St. Luke's, pag nag-swab kami, meron kaming tinatawag na COVID biofire exam. Ibig sabihin, hindi lang SARS-CoV-2. Na-identify din yung like almost 20 other viruses and bacteria doon. Siyempre, mas prohibitive ang cost, mas mahal. Sa government setting naman, I also work in a government setting, wala kaming ganun. Sa ospital ng Maynila. Pero kapag merong chance na makapag-swab kayo at malaman nyo talaga na na-identify there is influenza A virus, then if it is really influenza A, the recommendation is to start oseltamivir twice a day for 5 days. And the dose depends on the weight. By the way, wala tong syrup. So ito ay tablet. So pinapa-paper tab natin ito. So again, oseltamivir is strongly recommended to be started ASAP within 36 hours of laboratory confirmed infection. So here are the doses. Pinapa-paper tab namin, tapos per orem. Pag paper tab kasi dinurog-durog na, pharmacist ang bahala dyan. But of course, the doctor is the one who writes the instruction in the chart, no? As to ilang milligrams ng paper tab ang ibibigay dun sa patient. How about the other treatments for PCAP? Vitamin A is strongly recommended with the high-grade evidence. Bronchodilators in the presence of wheezing may be given kasi meron tayong tinatawag na viral-induced pneumonia. Okay, mga viruses din. So, yeah, bronchodilator, I would encounter pediapulmonologists who would administer salbutamol nebulization as part of the management regimen. And although this has expert opinion, but then again, these are guidelines that may be modified or even changed in the course of time. Zinc is not considered as adjunct therapy for severe pneumonia as it does not have any effect in shortening recovery time. Sa studies, walang nakitang ganong effect. Vitamin D is not considered as adjunct therapy for severe pneumonia as it does not reduce the length of hospital stay. Mucokinetic and mucolytic agents are not considered also as adjunct therapy for pneumonia. And there is also insufficient evidence to recommend the use of the following as adjunct therapy. So, oral folate, probiotics, vitamin C, VCO, nebulization with saline solution, and steam inhalation. So far, insufficient evidence lahat ito. So, let us go through this table once again. So, a patient with fever, cough, this is supposedly tachypnea. Sorry about the error here. Fever, cough, and tachypnea as manifestations of pneumonia. So if there is pneumonia and the patient is poorly nourished, unvaccinated with onset of rashes all over the body, may rashes siya, let's say that the rashes appeared first on the hairline going down, and this is maculopapular. And prior to the onset of tachypnea, there was prodrome of 3 C's. Okay? There's high-grade fever, and then the 3 C's are conjunctivitis, cough, and colds. Yes, you get the picture. You might be dealing with measles. And we know that measles per se, being a viral infection, is you can send them home unless the patient with measles is now presenting with also respiratory distress because one of the common complications is pneumonia. So you might be dealing with measles with pneumonia. So pag ganyan, measles with pneumonia, definitely for admission. Okay? How about those with pneumonia and patient has cystic fibrosis, although wala dito sa Philippines, or patient has a chronic granulomatous disease, patient is a burn patient, or patient may be neutropenic. What could be the etiology for this? Yes, that's Pseudomonas. Okay? How about patient is a teenager or maybe a young adult living in a dormitory. Initial cough is non-productive. The patient has no signs of distress, little or no fever. Yes, you may be dealing with atypical. So again, papasok si Mycoplasma pneumoniae. What about patient? Ano kaya ang etiology? Patient has his own aviarium in his home. Pwedeng psittacosis, no? Ito yung, kung naalala nyo, this is called as parrot fever. Although this is a zoonotic infectious disease in humans caused by Chlamydia psittaci or psittaci contracted from infected parrots. History of eye discharge, na-mention ko to kanina during the first 5 to 14 days of neonatal period, as coughing pero not really in distress. Yes, that's chlamydia. Okay? And the last one, the last respiratory problem, no? You could be dealing with signs of disordered control of breathing. So what is this? Ito yung mga possible mayroong anatomic problem like neuromuscular disease, like GBS. Remember in the review of Pedia Neuro kanina? Yes, there is ascending paralysis of the leg muscles. So, may weakness, pataas. Tapos, kapag na-compromise at umabot sa diaphragm. So, this is one structural problem that may lead to a disordered pattern and control of breathing. It may be metabolic. It may be due to drug overdose or even increased ICP. Let's say, merong mass effect. Let's say merong brain tumor, tapos nandun na siya sa may respiratory path, the one that controls the respiration. And the patient may present with usually apnea or bradypnea kapag ganito, no? And it again depends on the for toxins or drug overdose. Of course, it depends on the poison or the toxin that was either intentionally or accidentally ingested. Okay? So all of these conditions have an underlying mechanism of what we call disordered control of breathing, wherein the patient may have variable or irregular respiratory rate and pattern, variable effort, shallow breathing, yung central apnea, no? And then normal or decreased air movement. So kapag ganito, it depends on the underlying problem, what the management will be. So for increased ICP, we stabilize the airway, we protect it, we stabilize also the cervical spine, and then we give pharmacologic therapy like osmotic agents such as mannitol and hypertonic saline. And then for poisoning, as I said, if we are able to identify the toxin, then if there is a particular antidote for that, we give that. If we're dealing with meiotic pupils, okay, most of the time that would be opiate overdose, so we could give naloxone to reverse the manifestations. So it really depends on the toxin. And again, if that is structural or neuromuscular disease such as GBS affecting the diaphragm, then of course we start the patient on mechanical ventilator support. I'm showing you this picture to demonstrate how this particular respiratory condition will affect the appearance of the child. So I'm talking about a series or paroxysmal cough, 5 to 10 series. I believe I mentioned this earlier. But of course, for the undernourished babies, it would have a more deleterious effect. So I'm talking about, again, a whooping cough. Kasi at the end of the series of cough, they tend to vomit or they become nauseated, no? Kasi sunod-sunod. Sa isang go lang yun, sa isang sumpong ng ubo. So, sunod-sunod literal. So, it's alarming because we've been seeing since last year a steady increase of pertussis among the young children. Pag ganyan, reportable yan, ha? May specific format na na-download from the DOH website, yung mga reportable cases, notifiable cases, no? Kasi they have to look into if there are clustering of cases in certain barangays or cities. Then, of course, DOH and the Epidemiologic Center would have a concerted action and effort to curtail the effects of this bacteria. And I'm talking about Bordetella pertussis, which is gram-negative coccobacilli. Again, this is through droplets, secretions from a respiratory tract of infected persons. So they're highly infectious from 7 days after exposure to 4 weeks after onset of the typical paroxysms. And the incubation period is an average of 1 week. Notable are the 3 stages. So you may catch them arbitrarily. 2 weeks has been assigned for each stage. So the expert said, okay, 2 weeks, 2 weeks, 2 weeks each for catarrhal, paroxysmal, and convalescent. For the catarrhal stage, this is the one that has really the most infectious stage, no? Wherein talaga ma-identify nyo sa clinical lang, clinical, purely or predominantly coughing patient. And again, the typical series of 5 to 10 coughs ending in a whoop. The following symptoms are usually absent. No fever, no malaise, no rash, no sore throat, no hoarseness, no tachypnea, no wheeze, no crackles, no nothing. It's just the cough that will give it away, that will give the diagnosis away. But you watch out for complications because of the effort of coughing. They may develop subconjunctival hemorrhage, okay, seizures, otitis media. There could be collapse of the lung, atelectasis, and they may have superimposed bacterial infection like pneumonia. But for purely pertussis cases, we give, of course, macrolide. This is for 10 to 14 days, erythromycin or clarithromycin or azith. Okay. Let us review this portion. This is a combination of your knowledge of pathology and as well as the clinical aspect of pediatrics. So, what etiologic agent comes to mind if the presentation is one that attaches to respiratory epithelium and there is sloughing off of the cellular debris and inflammatory cells and mucus causing airway obstruction? If you answered mycoplasma, you are correct. Okay. What etiologic agent comes to mind if you're dealing with pneumatosil abscess, cavitation, hemorrhagic necrosis, empyema, o yung mga purulent fluid, or bronchopulmonary fistula. Ito lang yung mga naka-highlight, tomatosil, empyema, abscess. Yes, that's staphylococcus. What about the etiologic agent if there is diffuse infection in the interstitium or there is necrosis of the trachobronchial mucosa and there's some local hemorrhage? Yes, that is most likely strep. Okay. What about local edema aiding in the proliferation of organisms and spreading into adjacent areas resulting in focal lobar involvement? Very specifically, they said this is strep pneumo. In Nelson, pag ni-review nyo, the number one cause of lobar pneumonia is Streptococcus pneumoniae. Halimbawa, kunyari may nakita, right lower lobe pneumonia, left upper lobe, left lower lobe pneumonia, consolidation, puting-puti. Dun sa mga lobes na yon, think of strep pneumo as the number one cause. Kapag right upper consolidation, right upper lobe, puting-puti, what comes to mind? In an infant or a toddler who is, let's say, bottle-fed, and then coughing for the past 3 to 4 days with fever, associated with after feeding, baka most likely aspiration pneumonia. Tandaan nyo, kasi di ba ang what is the anatomic appearance of your bronchi? Why does the aspirated material go to the right mainstem bronchus? Because it is wider and shorter. Okay, so most of the time kung may ma-aspirate man sila, ang tendency is to go into the right upper portion. So yun ang puting-puti. Again, right upper lobe consolidation. Please think of aspiration pneumonia. Can be treated with high dose of penicillin G or your ampicillin sulbactam IV. What about right middle lobe consolidation? Kapag right middle lobe consolidation, I'll give you the symptomatology. Weight loss, night sweats, coughing more than 2 weeks, unexplained fever, had a 1-week course of antibiotic but did not respond to the antibiotic. Obviously, no, talagang clinical features ng TB. So yung right middle lobe consolidation, puting-puti, think of TB. Okay? TB as the cause. Okay, let's answer this. What about types of cough? Staccato. Okay, yung parang short, sudden bursts of cough. That is usually caused by chlamydia. Again, that's a typical brassy type of cough. Brassy is like loud metallic barking cough. You think of Staphylococcus aureus, yung mga katulad na sa tracheitis, no? Barking type of cough like that of a seal. You remember it's croup? Okay, so that's para-influenza. Whooping cough, ano nga ulit ang etiology? You're right, Bordetella. Pwede ring cystic fibrosis, but then again, wala dito. Coughing most severe in the morning, what could be the etiology? Yes, pwedeng asthma, no? Nighttime and early morning. Maybe due to vigorous exercise. Don't forget, there is exercise-induced asthma. Habitual cough is when the patient is coughing but tends to disappear with sleep. So baka habitual cough. Or tight sounding cough with wheezing, of course, that's asthma. Okay. A quick look again at the differential diagnosis for upper airway obstruction that I mentioned earlier. This particular table is lifted again from Nelson Textbook of Pediatrics. I just like to highlight again the other differentials. I already mentioned croup. You know this as having fever, cough, colds, barking cough, and stridor. Other family members are ill. I mentioned earlier epiglottitis, which is presenting as acute high fever, sore throat, dyspnea, okay, drooling, hyperextended neck. No other family member is ill. The way to diagnose this is by direct laryngoscopy to see the cherry red swollen epiglottis. However, you have to be careful because you don't want to push the patient into having respiratory arrest. Okay? Kasi kung magang-maga yun, yung epiglottis, baka magsara, kailangan ma-intubate. So kapag sinisilip yon, double setup. Ibig sabihin, naka-ready na yung pang-intubate namin. The other differential for upper airway obstruction is infectious laryngitis. Ito sa lahat ng pinaka-mild. Kasi nga, no, sore throat, cough, wala, respiratory distress is unusual. You just have pharyngeal inflammation. Tapos ang vital feature dito is the hoarseness. No? Minamalat lang sila, which is of course out of proportion to the symptoms. I already mentioned croup presenting with steeple sign in the x-ray of the neck and the thumb sign in the acute epiglottitis. And for acute infectious laryngitis, since this is mostly due to viruses, you have just to give supportive management. The other differentials for obstruction is spasmodic croup. How is this different from infectious croup? So obviously yung spasmodic croup has something to do with allergens. Okay? So, 'di ba sa infectious croup, other family members are ill. Sa spasmodic croup, wala kang ibang exposure to other family members who have the same symptoms. But they share the same symptom wherein there is barking cough. Okay? But the medications would be the same. Like you give dexamethasone, and if there is severe distress, we also add nebulized epinephrine. And the last differential is, I mentioned earlier, tracheitis, no? This is like acute epiglottitis, considered one of the severe and could present as really an emergency condition involving the upper airway obstruction. So they're highly toxic looking, clinically toxic looking, high fever with a brassy or metallic cough. Again, I highlighted with tracheitis, they have copious, thick, purulent secretions. So the etiology for tracheitis is most commonly staph aureus, followed by MRSA, and then strep, pneumonia, and strep pyogenes. They are for admission. So tracheitis, you give vancomycin or clindamycin with a third-generation cephalosporin. The neck x-ray of someone who has tracheitis will show you the pseudomembrane detachment in the trachea. Okay, here. Parang may mga detachment, hindi even, or there is what they call irregular lining of the trachea. Okay, so usually yung mga na-vomit nila or na-expectorate nila na mga purulent secretion, sometimes sobrang kapal, baka may mga membranes doon, no, coming from the airway. And then we review primary tuberculosis or pulmonary tuberculosis and extrapulmonary tuberculosis. To answer this, okay, in most children, the only evidence of primary TB is the evidence that you could see is recent conversion of PPD to positive. Okay. And please remember that still the most common extrapulmonary form of TB in children is, if you answered B, you are correct. That's scrofula. So yung mga malalaking kulani dito na pwedeng na-infect na, no? It's still scrofula, the most common extrapulmonary form of TB. I will now go through the National Tuberculosis Program of the Department of Health 2020 guidelines. Guys, downloadable for free if you have time to go over this. It discusses their identification, diagnostics, and management for adults and pedia patients with TB. So, presumptive PTB refers to any person having 2 weeks or longer of any of the following. I mentioned this earlier. Ito na ngayon yung definition niya, no? Pwede mo nang sabihin, okay, presumptive PTB na ito. If 2 weeks or longer, may cough, unexplained weight loss, unexplained fever, night sweats, or chest x-ray findings suggestive of TB. What about presumptive extrapulmonary TB outside the lungs? So anyone who have signs and symptoms specific to the suspected extrapulmonary site with or without constitutional signs and symptoms. Okay, so that already is presumptive extrapulmonary TB. Now, there are also terms like bacteriologically confirmed or clinically diagnosed TB. So from the term itself, pag bacteriologically confirmed TB, definitely the patient underwent or submitted a specimen that turned out to be positive either by smear microscopy, culture, or and they underwent rapid diagnostic tests. Nowadays, we use expert gene or gene expert, no? For clinically diagnosed TB, this is a patient for which the criterion for bacteriological confirmation is not met, but diagnosis is made on the basis of clinical findings, chest X-ray abnormalities, and a suggestive histology and or biochemistry or imaging tests. Okay? So it's either i-commit mo na sa sarili mo na yung dinidescribe sa na case-based questions sa exam, may binanggit na findings na nag-positive sa gene expert, so that's bacteriologically confirmed already. Or walang mga sinasabing culture test results, pero merong mga signs and symptoms mentioned earlier, then that's clinically diagnosed TB. Okay? For systematic screening of TB in 15 years old and above with unknown HIV infection status. Okay, so following again the symptomatology mentioned earlier. So kung wala naman anything, no, so chest x-ray, magpapagawa daw ng chest x-ray. Is the chest x-ray suggestive of TB? No. So titigil na doon, no. Pero kung may findings sa chest x-ray, then that is presumptive TB, again for the 15-year-old and above, then we request gene expert. If you will notice, gene expert now is the gold standard for diagnosing TB, not the AFB smear anymore, but rather the gene expert based on the 2020 guidelines. Now, for those who do not have the cardinal signs and symptoms, yun, no? Ito pala yung explanation nun. We offer chest x-ray, no? As I said. They are also trying to pick up those patients, especially if they are living with HIV patients, no? So, kailangan talaga mas-screen, kasi nga immunocompromised sila. So, mas-screen both chest x-ray and symptoms done at the time of diagnosis of HIV/AIDS and annually thereafter. Now, for screening for extrapulmonary TB for all ages, gibbous deformity. Ibig sabihin nito, guys, yung sa spine, kasi di ba meron tayong tinatawag na TB of the spine o Patch disease. So, kung na-involve na yung portions of the spine, no, then that's gibbous deformity. And then, presence of non-painful and large cervical lymphadenopathy or baka nga nag-develop into scrofula, nuchal rigidity and or drowsiness kasi baka TB meningitis na, pleural pericardial effusion, distended abdomen with ascites, non-painful and large joints, baka TB of the joints ito, and signs of tuberculin hypersensitivity too. So, what about approach to diagnosis of TB in 15 years old and below? Okay? So, halimbawa, presumptive TB muna tayo. For presumptive pulmonary TB, okay? So, kung kaya talaga ng sputum, yun ang sample for gene expert, no? GENE, gene expert. Yung ang pinoprocess nila yung sputum. Younger children, we may do gastric lavage. The thing is, quite challenging siya kasi sa outpatient department, we ask them to come back 3 consecutive mornings. Sometime in some institutions, kahit once lang, pero dapat first thing in the morning, as they, dapat nga, ideally, nandun lang sila sa gabi para overnight, first thing in the morning, makapag-lavage, NSS, tapos the first aspirate na makuha from the gastric area, that would be the specimen sent to the lab for gene expert. Again, this is for younger children. Okay? What if in the gene expert test, okay, it turns out to be positive NTB, whether positive or negative to identification of rifampicin resistance, that already is bacteriologically confirmed TB. Remember, galing yan sa sputum or gastric lavage. So, meron tayong specimen na tinest, so bacteriologically confirmed. Halimbawa, negative siya, cannot expectorate, that is the time we request for chest x-ray. What if there is the findings is strongly suggestive of TB with clinical signs and symptoms? This is the time that we use the term clinically diagnosed kasi walang sputum, walang lavage, x-ray lang with symptoms. Pwede pa rin daw matag as clinically diagnosed TB. Okay. Walang sputum, walang lavage, nagpa-x-ray, the x-ray turns out to be normal or uncertain. What is the next thing to do? Whether normal or uncertain, cannot commit kung may findings sa x-ray. We can give a trial of antibiotics. So, halimbawa, yung antibiotics mo, ano yun? Dahil nga strep pa rin, yung commonly involved na condition, you can give your coamoxiclav. Okay? So, kapag wala siyang response doon, no, magpa-follow up ka talaga after 2 weeks. If signs and symptoms persist, tapos if there's a contact of a known TB case, may classify now as clinically diagnosed. If not, if no contact or if no exposure to an adult or adolescent with TB, this is the time we do PPD testing or tuberculin skin test. If the tuberculin skin test, nagpa-PPD ka, di ba, intradermal na nilalagay yon dito, 0.1 units intradermally, ask them to come back after 48 to 72 hours. Pag nag-positive yon, clinically diagnosed TB ulit. Halimbawa, yung PPD nyo negative or unavailable pero persistent pa rin yung signs and symptoms, we now refer them to a specialist, no, to a pediapulmo for further assessment and management. Okay? What about those whom we are suspecting that there is extrapulmonary TB? So, ganun pa rin ang pathway. So, we try to get a sample for gene expert. Okay? So, ito pa rin yung magiging algorithm natin to identify whether the patient has extrapulmonary TB. So, ganun pa rin, samples, sputum or gastric lavage. Halimbawa, samples cannot be collected. That's the time we refer to, a specialist for further investigations. Okay. I'd just like to emphasize, this is the explanation, further explanation of that algorithm that I just showed you in the previous slide. But some additional features and considerations for clinically diagnosed TB. Kung meron kayong markedly enlarged unequal hilar lymph gland na palpate, no, more than 2 cm, so that's about more than an inch, 2.5 cm more than an inch, with or without opacification, miliary mottling, large pleural effusion, no, common in more than 5 years old to, equal or more than 1/3 yung fluid sa affected pleural cavity o sa side, or apical opacification, but alam natin pag nasa apex tas may nodes puting-puti, this is rare in younger children but common in adolescents. So these are the additional findings that make us lean towards clinically diagnosed TB. Okay? So ulitin ko lang, pag chest x-ray finding is normal, uncertain, or the child is stable, follow up talaga after 2 weeks kasi di ba magta-trial tayo ng antibiotics broad spectrum, the choice of which would be coamoxiclav. Okay, so this one is the big version of the explanation of the diagram kanina. Okay. Now, retreatment. The patient has already been treated before with anti-TB drugs for at least 1 month and includes the following, no? Relapse. Pag gagamitin niyo yung term na relapse, declared cured and completed treatment but is presently diagnosed with active TB. So, nag-relapse yun. What about treatment after failure? Previously treated but failed most recent course based on a positive smear microscopy follow-up at 5 months later. So may timeline, may specific, no? 5 months later, meron pa rin. So ang tawag nila doon, treatment after failure. Importante to, treatment after loss to follow-up. Ang definition nila dito, previously treated na but lost to follow-up for at least 2 months. At least 2 months na wala. Kasi di ba dapat DOTS, directly observed therapy. But ang ginagawa kasi ngayon, lalo na sa pedia, 1 month, pinapabalik sa ospital para, lalo na sa government setting, no, pinapabalik to give the set of medications good for 1 month. Pero kapag hindi na nila nakikita yung patient, 2 months or more, then yeah, after, lost to follow up ang tag nila doon. Or there's also other subgroups like previous treatment outcome unknown and patients with unknown previous TB treatment history. I just like to emphasize again the primary diagnostic tools that are WHO endorsed to be used, no, for diagnosis. So again, expert or gene expert, that's for Mycobacterium TB and rifampicin resistance. This is a molecular assay, a rapid test that detects MTB and rifampicin resistance. In some national hospitals, no, or DOH accredited hospitals and centers, not all kasi, some may have TB lamp instead of the gene expert. LAMP is loop-mediated isothermal amplification. It's also a molecular assay that can be read with the naked eye under ultraviolet light in under an hour to detect MTB but cannot detect rifampicin resistance. So, ang advantage ng gene expert na identify niya yung rifampicin resistance. Merong iba, line probe assay. But then again, no, it depends on the institution or the DOH center or DOH accredited hospitals, whatever is available in their institution. Smear microscopy is the conventional test that serves as a basis for diagnosis of TB. So, yung pa rin, no, microscopic na sputum for microscopy yun. TB culture and drug sensitivity test is used in diagnosing and monitoring treatment response for drug-resistant TB and for prevalent studies and drug-resistant surveillance. So, ang maganda sa gene expert, MTB, and rifampicin assay, in less than 2 hours, you have a result. The meta-analysis studies have shown the diagnostic accuracy in children. It's quite a range, but it could detect as high as 90 to 100%, no? Especially for sputum. And for gastric lavage, you have a range of 40 to 100%. That's why WHO has recommended gene expert as replacement for the conventional smear microscopy of sputum. Okay? And the other adjuvant or ancillary diagnostic tools such as chest x-ray, it has low specificity to detect TB. It cannot differentiate drug-sensitive from drug-resistant TB, definitely. The tuberculin skin test is still a basic screening tool for TB infection among children, but not a mandatory tool, and its absence is not a deterrent in diagnosing TB. Okay? But if you use this, the interpretation is that it is positive if there is induration or pamamaga or nakaangat, raised yung skin of more than 5 millimeters in immunocompromised children, or the cutoff is more than 10 millimeters in children regardless of BCG vaccination. What about IGRA? You might have heard of IGRA or interferon gamma release assay. What they use here is blood. Diba? Sa gene expert is sputum or gastric lavage sample. Sa IGRA, blood sample mixed with antigens specific for MTB complex strains and absent from the BCG vaccine strain. So, ang tinitingnan doon, the WBCs from the infected person supposedly release interferon gamma as a marker of infection. So, a positive result suggests that MTB infection is likely. Commercially available and FDA-approved IGRA tests, baka naririnig nyo na rin, yung TB Gold test, okay? Or LI-SPOT or TB or T-SPOT TB test. Okay? The results are available in 24 hours, but it's not affected by prior BCG vaccination. This is much more expensive, needs to be processed immediately, and still to date, there is paucity of data for its use in less than 5-year-old children and immunocompromised patients. So, medyo limited pa yung utilization niya for this age group. So, tuberculin skin test and IGRA generally should not be tested on persons with low risk of TB infection and TB disease. They can neither distinguish active TB from latent TB. IGRA can distinguish latent TB from a previous BCG administration though. So again, routine testing with IGRA is not generally recommended. And again, TST is preferred. The skin test is preferred over IGRA in children less than 5 years old. So rather than IGRA, pag less than 5 years old, a screening tool, still we use tuberculin skin test or yung PPD test. Now, I'd like to emphasize the 4 anti-TB medications that we start the patient with once we diagnose them with pulmonary TB. Of course, we're giving INH, rifampicin, PZA, and ethambutol. For INH, it's a range of 10 to 15 milligrams per kilo per day. For rifampicin, we warn the patients that the urine might turn out to be reddish orange or orangey, and the parents might get anxious or panic, but you have to assure them that this is just a reaction of the rifampicin in the urine. So the dose is 10 to 20 milligrams per kilo per day. PZA is given at an average of 30 milligrams per kilo per day, and ethambutol at 20 milligrams per kilo per day. The fear of having optic neuritis as an adverse effect of ethambutol, experts have already shown that for as long as you give the dose of ethambutol within the range, there is little chance or less likelihood that they will develop the dreaded complication of optic neuritis. So to remember that ethambutol ay mata. Okay? So yun ang common yan na side effect, no? Optic neuritis. But then again, if you're giving the dose within the range, then there's no fear of having optic neuritis. So here is the treatment regimen for drug-sensitive TB. Regimen 1, if you can see, it's a total of 6 months. Let me emphasize again, 6 months. But the first 2 months, we use 4 anti-TB drugs now. Again, INH, Rifam, pyrazinamide, ethambutol. After 2 months, we just use INH and rifampicin to complete 4 months. This regimen is for pulmonary TB or extrapulmonary TB, except CNS, except TB of the bones or Pott's disease, except TB of the joints, whether new or retreatment with final gene expert result. Okay? So ito yung mga binibigay. However, the next regimen is a total of 1 year, 12 months. Wherein the first 2 months, it is still the 4 anti-TB drugs, 2 months of INH, Rifam, PZA, ethambutol, and the rest, 10 months of INH and rifampicin. Sino ang binibigyan ng 1 year? Extrapulmonary TB involving CNS, so that is TB meningitis, Pott's disease or TB of the bones or the spine, TB of the joints, whether new or retreatment, with final gene expert result. Okay. So again, to summarize the duration of treatment, basically for drug-sensitive TB na pulmonary TB, 6 months, 12 months kapag mga extrapulmonary TB. Pero kung drug-resistant TB, the recommendation of experts is a duration of 9 to 20 months. What to do if there are adverse drug reactions? So, some GI intolerance, so masakit, some epigastric discomfort, nauseated, vomiting, you usually expect this from INH, rifampicin, and PZA. So how to manage? Give drugs at bedtime or with small meals. Mild skin reaction like redness, slight pruritus, it can be expected from any of these drugs. We just give antihistamine. Orange-colored urine, as I said, expected with the use of rifampicin. Just reassure the patient. Once rifampicin is discontinued, then yes, the color goes back to normal. Burning sensation in the feet, that could be due to isoniazid. So we give vitamin B6, 50 to 100 milligrams daily for treatment. For as long as we are giving isoniazid to the patient. Adverse reaction of arthralgia due to hyperuricemia may be related with pyrazinamide, so we give NSAID, and if persistent, we consider gout and request for serum uric acid and refer to a subspecialist. For flu-like symptoms, this could be also secondary to rifampicin. We just give antipyretics. Severe skin rash due to hypersensitivity, definitely we stop the anti-TB drugs and refer to a pedia-pulmo. Jaundice due to hepatitis, especially from INH, Rifam, and PZA, we stop the anti-TB drugs again and refer to a subspecialist. I mentioned optic neuritis involving the eye, eye, ethambutol. Okay? Stop the ethambutol, refer to ophthalmologist if they have changes in the visual acuity, blurring of vision, and difficulty in identification of colors. Oliguria, albuminuria can be due to a renal disorder, maybe because of rifampicin. Stop the anti-TB drug again, refer to a specialist. Psychosis and convulsions may be secondary to isoniazid. Again, we stop the medication, refer to pedia-pulmo. And lastly, if there is thrombocytopenia, anemia, and shock, may be because of rifampicin. Again, all of this would warrant discontinuation of anti-TB drugs and referral to pedia-pulmonologists. So I walk you through hopefully one of these conditions, pneumonia, okay, TB, okay, pertussis, okay, the 4 mechanisms of respiratory problem like upper airway, you have croup, okay, you have or croup or LTB, and you have foreign body aspiration. You have lower airway obstruction like asthma and bronchiolitis. You have pneumonia as an example of the problem of lung tissue damage or restrictive lung disease. And then you have disorders of control of mechanism. That would be secondary to neuromuscular, to toxins, to increased ICP and metabolic problems. And hopefully, you will be able to encounter this not only in the exams, but also in actual cases wherein you will be able to remember all of these things and give the appropriate management. Okay, that's all for pedia-pulmo.